we are starting with. All right, so today we are starting with the various forms of injuries when it comes to musculoskeletal. We cannot do musculoskeletal and not talk about fractures, not talk about fractures are the main things when it comes to bones. So we need to talk about bones, we need to talk about muscles, what happens to them. But so before I start, if you have something you want to bring on board, you can draw my attention to it. So we are starting with injuries. And the injuries, as we know that we have to use our muscles in performing a lot of daily, day in, day out activities. If the muscles are too much burdened, okay, it could lead to some form of injuries to the muscles and the tendons, so as well as our ligaments. So we have to look at the various terms that are related to each of them, because if the muscles and the tendons are affected, it has a term for it. If you have the ligament also affected, we also have the name outside or the term that is good for it and how to basically go for it. Now, these are a little bit more, much more minor injuries that we do encounter, even though some can be much more intense or much more severe, especially if you follow football a lot. I mean, overstretching of your muscle alone. I mean, your coach can tell you that you have to stay home for some time, for maybe a week or two. And then after that, I mean, they will reevaluate you and then you come back to field. So those are the instances where one could encounter this form of injury. So the first injury we'll talk about today is strain. And those strains are when the muscles or the tendons are stretched excessively. So when you stretch your muscles or your tendons too excessively, it becomes strain. So it will be very, I mean, funny when you meet a question of this sort and then you are like, is it strain or is it sprain? So you need to know the two. So when the muscles are affected, the muscles or tendons, so strains are excessive stretching of a muscle or a tendon. The cause of it, like I said, when the muscles are too much burdened, it could be that, let's say you are playing football, you are engaging in exercise, and you overstretch a muscle, okay? And that is what could lead to the injury. When it comes to strains or muscle injury or tendon injury, basically there's going to be severe form of the pain is mostly moderate to severe. It depends on, I mean, the intensity of what we call the sprain or the injury. Management, basically they are going to apply cold and heat compresses could be applied. So both could be used in managing what we call sprains. Exercise with activity limitations. So mostly with this form of, I mean, injury, you tend to limit exercise, even though, so exercise with activity limitation. So basically the area will need to be rest a little, even if the person will be allowed to engage in exercise, moderate form of exercise, probably maybe walking if with assistance, but not to engage in too much form of exercise that will put too much strain on what we call the tendons and that of the muscle. So clients will be asked to ensure some form of limitations when it comes to activity. Our NSAIDs are also useful. So anti-inflammatory medications just to help limit the inflammatory process that is ongoing. And then muscle relaxants are all useful. Surgical repair may also be required for severe strain, I mean, when it is ruptured. So when you have the tendons or the muscles ruptured, so when the injury is severe or too much, like intense, then surgery will be recommended for the individual. So the footballers you see, some of them, they will just sustain some form of muscle injury. Others will require surgery. Others will also just be told to, I mean, rest for some few days and then the person get back to the field. So it depends on the intensity of the injury or the severity of the injury that will determine the kind of treatment option the healthcare provider would have to provide for that very person. So when it comes to strain, what I just want you to understand, it affects the tendons and that of the muscles. That is strains. In management, sorry, we use cold or warm compresses. Each of them can be used. Exercise limitation has to be ensured. NSAIDs and then muscle relaxants are the useful, management here. Then when it comes to the second one is sprain. So we have strain, we have sprain. Sprain talks about ligaments. So excessive stretching or tearing of a ligament, usually caused by twisting motion, such as a fall or stepping onto an uneven surface. So when you get the ligaments stretched out too much, okay, which can occur as a result of a fall or when you step on something that is uneven, okay, it can cause that to happen. When this happens, there's going to be pain, it's going to be swelling. So sprains are much more characterized by pain and swelling. When it comes to the management, so we use the mnemonic RICE, so RICE. That is a mnemonic for managing someone with what we call a sprain. So we use, first one is to rest the area, apply ice compress or apply ice on the area, and then a compressed bandage. So you apply bandage and then elevation to help reduce the swelling, as well as joint support. So RICE is considered a first aid treatment rather than a cure for soft tissue injury. So let's say you have, I think some of us might have met a question on that. Where you need to apply the RICE. So you need to have RICE at the back of your mind that whenever you get a question on, a sprain and they are asking of what will be your order of intervention, you need to understand that the first thing you need to do in this instance is to, rest the area. That resting the area, you need to apply ice on it. After applying ice, then bandage or compressive bandage will be applied, and subsequently elevating the affected extremity so to help reduce what we call swelling. So when it comes to management, that is what goes in there. Casting may also be required for moderate sprain to allow the area to heal or to allow the tear to heal. Surgery may also be needed if the injury is too much severe or when you have the ligaments being severely damaged. Surgery can also be performed for such individuals. So that is on what we call sprain and then strain. Finally, hey, today we did not give what is it? So let us unmute up, okay? So that we prevent some. I muted her. Madam Regina, you are unmuted. We are getting feedback from you. Kindly mute up for us before you are taken up. All right. So that is on sprain. And then what you do for a client is what we call them. Oh, yes, it can equally be used. Hey. But I muted her up. Where is she? She's gone. We have rotator cuff injury. So the rotator cuff injury, those of us who engage a lot in playing what is it? Table tennis or tennis. Okay, those who play tennis a lot. Those are the people that are mostly, get this form of injury. Or if you are the type that you use your rotator cuff a lot, that is your shoulder. Okay, you know the rotator cuff is at the shoulder. Okay, so those people who like using the shoulder a lot in engaging in exercise or engaging in activities, those are the people who are mostly affected when it comes to the rotator cuff. Well, it can equally affect anybody at all. Like, let's say you fall from a height and then the shoulder gets affected. You can sustain what we call rotator cuff injury. So rotator cuff injury is when you have the muscles and the tendons at the shoulder joints, okay, or the rotator cuff of the shoulder when it sustains a tear, okay, usually as a result of a trauma or chronic wear or tear, chronic wear and tear overuse. So overuse is in a case of, let's say, when you are playing tennis, you know, those people like is it Serena Williams? Serena Williams is a tennis player. You know, when it comes to tennis, they can engage in tennis for more than 6 hours and they are still playing the tennis. And so when you engage, you continue to use the shoulder, or you continue to use the area for activities or whatever you are doing. It can lead to what we call wear and tear or overuse. And that could cause, a tearing of what we call the rotator cuff or the muscles and the tendons at your shoulder. And that is what we call rotator cuff injury. The injury is typically characterized by shoulder pain and inability to maintain adduction of the arm. So adduction of the arm is where you'll be asked to move the arm away from the body. And so you know that when the area is injured and then there is that form of injury, it's very difficult for the individual to move the hand away from the body. That is adduction. And so these people tends to have severe pain or shoulder pain and inability to maintain adduction of the arm at the shoulder. And that we call it the drop arm test. So the drop arm test is mostly used to assess for whether there is any form of injury to the shoulder. And so the healthcare provider or the examiner would have to move the hand away from the body, just like I was saying with the adduction, so that they raise it up to see if the person can sustain that form of arm movements. And so such people tends to fail when it comes to drop arm test. So that is on rotator cuff injury, when and what to expect. Over here, NSAIDs are very key. You need your NSAIDs. You need physical therapy, to help with the area. Then we need a sling. So a sling for support. You know how a sling is, they will apply it and then it's like they will move the arm towards the other hand and then they will apply bandage over it. So sling support is also useful. And then ice heat application is also important to reduce the pain and then also ensure blood flow to the area. Surgery may also be required if medical management is unsuccessful or complete tear is present. So depending on the level of the injury or the severity of the injury, the healthcare provider can equally opt for, or surgery can equally be of choice, depending on what we call the severity of the injury. So these are some form of injuries or some injuries we need to know when it comes to, the musculoskeletal. Before we go into fractures itself, and we talk about fractures basically, then we go into fracture care as well. So that is what we call sprain, strain, and then rotator cuff injury. If you have an input you want to make based on whatever I've said, or you have a question you want to ask, you can bring it up. Fractures, as we all know, when there is a break in the continuity of the bone. Okay, so a break in the continuity of the bone is what basically we call fracture. Now, anyone here knows the definition of fractures or a fracture? No one here would say that. As for me, I don't know fracture. Before I learn fractures, but this is just a reminder of what about length. Is there a break in the continuity of the bone? As a result of a trauma, twisting, as a result of muscle spasm or indirect loss of leverage, that is balance, or bone decalcification and the diseases that result in osteopenia. So, fracture can be as a result of a trauma. Let's say you are playing football, or let's say you get involved in a very traumatic road traffic accident, and there's that kind of break in the continuity of your bone. That's what we call fracture. Fracture can also be as a result of imbalance. When you get indirect loss of, leverage or balance. Let's say you step on, a surface, and then, you didn't get the balance well. You can fall down, and then there's going to be a form of a break in your, in your bone, and so fracture can happen, or bone demineralization, any form of, condition that causes, bone decalcification, calcium level to drop in terms of the bone. And you know that you need calcium for bone strength. And so pathological fractures, let's say immobility, you know that when one lies down for a very long time, the bone, in terms of the calcium, tries to break down. And so the person loses that bone, strength through decalcification. And then other condition that can also affect, the ability of the bones to also absorb what we call calcium to enhance bone strength. And so all these things are some factors that can lead to what we call fractures. When it comes to fracture, I know we all know the various types. Sometimes you can get a question asking of types of fracture. Describe the form of injury for you and actual type of fracture it seems it is. And so we have close, simple fracture. So we have types, a lot of them. We have close, simple, we have compound, we have comminuted, we have complete, depressed, green stick, impacted, incomplete, oblique, pathological. A lot of them are there. You see those of us following on the screen. So when it comes to close or simple fracture, we are talking about skin over the fracture remain intact. So you have someone, who comes with, let's say, a certain form of injury. The affected area, you look at the skin and you realize that everything is intact, but deep within there is a break in a bone. And so that is what we call simple or close fracture. So close fracture or simple fracture is where you have a break in the continuity of the skin, the bone. However, the skin remain intact. Nothing happens to what we call the skin. And so that is what we call close or simple fracture. Then we have compound or open fracture. So this time around, like the name goes, so just opposite of what we call simple or closed fracture. This one is compound or opened. So the bone is exposed. So there is a break in continuity of what we call the bone, and as well as the skin. So there is also a break in the skin and that of the bone. So this time around, the bone is what is exposed. So the bone is exposed to air through a break in the skin, and then soft tissue injury infections are common. So when it comes to compound or open fracture wounds, this type of wounds are more susceptible to infection because there is a break in the skin integrity. So bacterial infection is very common. And so these people are tend to be prone to what we call, infection. We have communicated, how do you pronounce it? I want to get it right. Communicated, yes. I like it. Comminated.
Comminuted.
Comminuted. All right. All
Yeah.
right. Comminuted. Thank you. And so we have comminuted for fracture. The bone is splintered, okay, or crushed, creating numerous fragments. So this type of fracture is not the one that you just have like a straight cut or a straight break. And so this type of injury, you tend to have the break in the continuity of what we call the bone, and then you have numerous fragments created. Okay. Or like it's like the bone is crushed. You have like a lot of particles of the bone. So you take a comminuted. Yes, this time I got it right. Then we have complete. So the complete is, separated. The bone is separated completely by a break. So this time around, like the bone is break into two. So a part here, a part here. So break into two, just like you have a pen and you cut the pen into two parts. So if you have any form of fracture where the fracture results in a complete break, okay, in what we call the bone, that is what we call a complete fracture. We also have compression fracture where a fracture bone is compressed by one another. So you have one bone that is compressed by another one. That's also, compressed one. We have depressed one. The fractured bone kind of enter into the other. So, bone fragments are driven inward. So after the break in the continuity of the bone, you have the other bone kind of entering, or the bone entering inwardly. So even though there is a break, but after the break, you see the bone entering the other end. We have green stick fracture. So here, one side of the bone is also broken and the other is bent. These fractures are more common in children, and then kids like asking about this form of fracture. They will ask you which type of fracture is more common in kids or more common in children. You need to understand that um green stick fracture is more common in children. This type of fracture results in one side of the bone getting broke or break, then the other will bend. So this time it's not like the whole thing will break, like a part will break and a part will bend. And so that is what we call green stick. And it is more common in children. I want everyone to know this. Impacted fracture, just like depressed one. So where the bone drives into another one, incomplete. There's just a fracture line. So you just see the lines are there, okay, but it's not broken into two like how a complete fracture will looks like. So incomplete one is a fracture. The fracture line does not extend to the full transverse width of the bone. We have oblique. The lines will run at the edge angles across the angles of the bone. These are things when you just look for, you can see the various types. They will give you, I saw one picture, they were giving the various types, and they will give an example how it looks like picture form, so you could picture it. What I want to talk about again is pathological. Like I said, in pathological fracture, it is more common in people who have some underlying medical conditions that tend to affect the bone strength. So like immobility, if one lies in bed for a very long time, it affects the bone strength, and at the end of the day can lead to what we call fractures. So that is where if you are handling them, you don't handle them, you move them anyhow, the bone can break. And so we have pathological fractures as a result of weakening of the bone structure by pathological processes such as neoplasia, that is what we call cancers, and then also cause spontaneous fracture. So those are some of the things. So these are some of the types of fractures we have. I wouldn't want to go through all of them. The next thing I just want us to understand is what to assess for when it comes to fracture, and I believe we can all come up with this. In fracture, of course, pain will be there. The area, there's going to be some form of deformity of the affected area. On your assessments, you expect to see some form of crepitation, redness of the area, so erythema, edema, and then bruising, muscle spasm, neuromuscular impairment. So in neuromuscular impairment, what we are talking about, assessing for what we call blood supply to the extremity that is affected. Can the person feel pain? Are the nerves affected? How is the capillary refill over there? Is there any form of indication that there's loss of blood supply to the area? So you need to do your neurovascular assessment to see whether there is any form of neuromuscular impairment. Then there's also decrease or loss of muscle strength or function. So if an extremity is fractured, you cannot make use of that extremity. We have pain or tenderness over the involved areas. And so these are some of the things that at least we need to know when it comes to fracture in terms of your assessment. With care of fracture, we go through the various forms of care, especially when it comes to traction, when it comes to the use of reduction and all that. But typically when fracture occurs, first thing you need to do is to immobilize the area. Okay. Immobilize the affected extremity with a cast or a splint. And so you are not allowed to manipulate the fracture. Then try to pull the affected extremity to ensure alignment. No, that is not your duty. The moment you notice that an extremity is affected in terms of fracture, your duty is to immobilize it. And so in immobilization, we either use a splint, okay, where you look for, I mean, at our setting here, you get some cardboard and you cut it and then you try to wrap it at the area. So you mobilize it so that the joint does not move. Okay. So to prevent the joint or the affected area from moving. So, and a cast, we all know casts, plaster of Paris. We'll talk about cast care in details. You need to do your neurovascular assessment. And so the neurovascular assessment is where I was saying that you need to assess the extremity for blood supply. You need to assess You need, all right. You need to assess the extremity for blood supply. Is there any form of nerve issue? Is the person not able to feel pain at the area? How is the capillary refill at the area? So you need to assess for what we call the bone, the neurovascular assessment of the area you need to assess. Then for opened or compound fracture, we need to splint the extremity, like I said. After splinting, you need to cover the wound with a sterile dressing, because we said that with open or compound fracture, the concern here is what? The concern is much more of infection. Just a minute, let me drink. Just a minute. Are you successful? Great. So I was talking about compound fracture. That in compound fracture or open fracture, you don't try to manipulate the fracture, just like I said. You need to splint. After splinting, you don't leave the area open. You need to cover the area with a sterile dressing, okay, to prevent infection. Then when it comes to, further interventions, we have your reduction, we have fixation, we have traction, we have cast. So that is it. We go through the various interventions and then get to understand them. So that is with fractures and then the general overview and general interventions here. When it comes to the various interventions that are available, we have, first one we'll talk about is reduction. And the reduction is done to help restore the bone to proper alignment. And so that is where the healthcare provider will try to manipulate the area, okay, either by pulling the joints or by pulling it so that to ensure alignment. So reduction, and so reduction can be done close. We have close reduction, we have open reduction. So in close reduction, just like I said, sometimes they try to pull the affected joint or the affected extremity so that, to ensure alignment. So in close reduction, it is a non-surgical intervention performed by manual manipulation of the affected joint. Then we have, because of pain issue, clients will need some form of local general anesthesia to help control the pain involved in what we call close reduction. Then we have, after the reduction, mostly a cast will be placed or a cast will be applied to ensure proper alignment of the area. We also have open reduction. So in open reduction, it involves surgical intervention where the fractured extremity will be operated on, and then pins, screws will be applied inside, or they will open inside. Sorry, surgical, it will involve surgical procedure where, the fractured joints will be opened up and then probably pull the edges and then to ensure alignment. I think I was talking about fixation because you could get open reduction internal fixation. Yes. So after opening up the joints, then they will now apply what you call the pins and the screws together so as to ensure what we call proper alignment and proximity of the affected extremity. So that is on reduction. So reduction, we have open reduction, we have what we call closed reduction. Closed reduction, it's non-surgical, manual manipulation, a general anesthesia or local anesthesia may be useful. Open reduction, it involves, surgical intervention where the fractured area will be treated with internal fixation device. Yes, so after opening up, they will now have to put in what we call the screws, the pins, and all the wires. So let's now talk about fixation. So if you've come across ORIF before, ORIF is just open reduction internal fixation. So after opening, okay, then they will now add the screws to it, mostly useful in what we call hip fracture. Okay, so with fixation, it involves internal fixation follows open reduction. So after open reduction, they will definitely add up the screws and then the plates. So internal fixation will involve application of what we call screws, plates, pins, wires, or in intramedullary rods to hold the fragments in alignment. So after opening up the area, of course they will need to add up the screws and all that. Those of us who have worked in orthopedic units before, we know all these things, okay? Or we might have come across these things. Clients who goes in, they tell you that I have pins in my bones. So it means that the person went in for open reduction internal fixation. Internal fixation may also involve the removal of damaged bone and then replacement with what we call prosthesis. So after opening up the area, the healthcare provider realized that affected, there is some form of damage to some of the bones. They would have to take those fragments off so that they can use prosthesis or artificial prosthesis to replace the damaged bones. Internal fixation provides immediate bone stabilization, and so it helps to ensure immediate. The moment they finish up, maybe clients would have to go through some form of rest periods and then treatment, but it ensures proper alignment and then immediate bone stabilization after they do what we call fixation. We also have external fixation, and so with external fixation, the use of external frame to stabilize what we call a fracture by attaching a skeletal pins to bone fragment to a rigid external support. So you see that someone with injury will come and they have some form of skeletal pins that is attached to what we call the bone externally. So you can see that one, but for internal fixation, you cannot see the pins. They finish and they close everything up. But with external fixation, you still see the pins, or you see the appliance is mostly outside when it is attached to what we call the bone. The external fixation provides freedom of movement than traction. So we'll talk about traction very soon. When it comes to traction, we are using weights. Okay, the weights will have to be applied in order to pull the affected joint together to ensure. So in terms of traction, you are not able to move around. But when it comes to external fixation, the client is able to move, or the client is able to move around, yes, with assistive devices. Morbidity in external fixation, some of the things you have to do is to ensure that you monitor the pins that are attached for stability, and then you provide pin care to help reduce infection. So here too, infection is very key here. So if you have a client with external fixation, you would need to make sure that you are providing meticulous skin care when it comes to the area where the pins are attached. So you need to dress the area, and then you need to watch the area also for risks of infection. So risk of infection also exists with both fixation method, but it will be much more common when it comes to external fixation because that the pins are more exposed. Okay. Then external fixation is also commonly used when massive tissue trauma is also present. So that is with fixation, and then the various types of fixation we also have. internal fixation, and then we have external fixation. Okay. And then we talk about traction. So in tractions, I might need to use pictures to also help us here. And so after this, probably I'll show the pictures when it comes to various forms of traction. So when it comes to traction, we know that when it comes to traction, traction involves, the exertion of a pulling force that is applied in two directions to reduce and immobilize a fracture. Okay. And so for those who have gone to orthopedics units before, you enter there and you realize that someone is lying down, has some bucket that is attached to the lower end of the bed with some form of weight inside it. That is what we call traction. So we have different forms of traction. We have skeletal traction, we have back traction, we have a lot of them. We have pelvic traction. Mostly depends on the area that is affected and the type of traction that the individual will use, or the healthcare provider will use. So the involvement of the extremity or the area involved in the injury would determine the type of traction that's supposed to be used. It helps to provide proper bone alignment and reduces what we call muscle spasms. Okay, so that is with what traction does. When it comes to interventions for traction, even though we go through the various types of the traction, but generally when it comes to traction, you need to maintain proper body alignment when it comes to traction. So maintain, proper body alignment. You need to ensure that the weights hang freely and do not touch the floor. And so traction care is also one of the key areas when it comes to the ankle. So you need to make sure that the weight hangs freely. It does not touch the floor. You do not also remove or lift the weight without the healthcare provider's prescription. Let's take note of these options. And so you are not allowed to lift what we call the weight. Okay, when you are moving the client, you will need a healthcare provider's prescription or order for that to be done. Or do not remove reduce the weight, either reduction or removing the weight. You are not supposed to do until the healthcare provider has given that kind of order. Ensure that the pulleys are not obstructed and that the ropes in the pulleys move freely. And so you need to make sure the pulley systems are not obstructed. That is what is pulling what we call the joint. And then you need to make sure that it hangs freely without any form of obstructions. You need to place nuts in the rope to prevent any form of slipping. You need to check the rope for, any kind of issues with the rope, because you don't want the rope to tear. So you need to check the rope for any form of frying. That is with traction general care. When it comes to the various types, we have skeletal traction. And so the traction is applied to what we call the skin, mostly like lower extremity, like the foot is affected, and then the traction will be applied directly. Like I said, I'll show you the pictures of the various forms of tractions that we have, and then we can appreciate it more. In skeletal traction, the traction is applied mechanically to what we call the bone with pins, wires, or tags. The weight that is mostly used is between 25 to 40 pounds. That is about 11 to 48, 11 to 18 kilogram. That is the weights that are mostly used or typically used. You need to monitor the color, the motion, and sensation of the affected extremity. So that forms part of what we call neurovascular assessment. When someone is on skeletal traction, you need to monitor the pins, where the pins are attached for any form of infection. If there is infection, there's going to be redness, swelling, drainage, or increased pain. You need to provide what we call site care. The incision site care for infection purposes. You need to provide that. So that is with skeletal traction. I don't know if I should just do that one after the other. Then when I'm done, I just show the picture. So we have skin traction. Skin traction also involves applying it. So skin traction is more of applying, elastic bandage. So in skin traction, here pins are not applied. Okay, and so you see that they will just wrap what we call the weight with what we call a bandage, just a bandage applied to the affected joint. Then the traction will be applied. And so elastic bandage or adhesive foam boots or sling are mostly used. Here you need to be cautious to avoid excessive pressure on the skin, and that could result in a pressure injury or skin breakdown. So when you are wrapping the elastic bandage, you don't need to apply too tightly on the person. Wrapping too tight could also increase the risk of compartment syndrome. We'll talk about compartment syndrome very soon. And so these are some of the things we need to do when it comes to skin tractions, what you need to avoid. Basically, because it doesn't involve the application of pins and other things, skin care or meticulous skin care, or incision care will not be a concern. Infection will also, infection at the joint or at where the pins, because pins are not involved, so you're not going to be worried about what we call any form of infection assessment in terms of pin area or something like that. So here you just have to make sure that you don't tie the elastic bandage too tight on the person. That could lead to compartment syndrome. For cervical traction, mostly used in people with upper extremity injury. So this time around, the traction is mostly applied at the upper extremity. So they will hang what we call the traction at the head side of the bed. So cervical tractions relieve muscle spasms and then compression in upper extremity and neck and the neck. The cervical traction uses a head, halter, and then chin pad to attach the traction. So that's what I was saying. So if you've seen that form of traction before where the traction is applied to what we call the head area to help relieve spasms within the upper extremity and then the neck. Use a powder to also protect the ear from friction. So that is one intervention we need to understand here. We also have, you need to position the client with the head of the bed elevated to about 30 to 40 degrees and then attach the weight to a pulley system over the head of the bed. So that is on cervical skin traction. We have back extension traction or back traction. So back skin traction or extension traction is also used to relieve muscle spasm and then immobilize lower limbs, okay, by maintaining a straight pull on the limbs with the use of weight. And so a boot appliance is also applied to attach what we call, to the traction. The weights are tied to a pulley. You need to allow the weight to hang freely over the edges of the bed, just like we talked about when we were talking about general intervention for what we call traction. The weights applied are mostly 8 to 10 pounds. That is about 3.5 to 4.5 kg. That is the weights that are mostly applied. So it's not mostly more than this. So it's mostly within this range. You need to elevate the foot of the bed to also help to provide the traction. That is on back traction. Then we have pelvic skin traction. So this is more of like those with pelvic bone injury or fractures. That those are the people that make uses of what we call them pelvic traction. And so with pelvic skin traction, it is used to relieve lower back, hip, or leg pain or to reduce muscle spasm. The tractions are apply the traction belts slangly over the pelvic and then iliac crest and attach the weight. So mostly the traction is mostly applied at the pelvic joint and then the weight will be attached to it. You need to use measures as prescribed to prevent the client from slipping down in bed. You need to make sure that weight is hanging freely. There's no any form of obstruction to the pulley systems and all that. We have balance suspension traction, which also, the tractions is used with skin or skeletal traction. So it's either they are using skin or skeletal traction. It mostly used to help with fractures that involve the femur, the tibia, and then the fibula. With balanced suspension traction, it helps to produce a counterbalance other than, the client. So the same thing, the interventions are that you need to make sure the client lies in a fowler's position or on either side, low fowler's position on either side on the back. You need to maintain a 20-degree angle from the thigh to what we call the bed. Abigail, kindly mute upwards. Abigail Sherman, kindly mute upwards. Protects the skin from breakdown. You need to provide skin care, especially if they use what we call skeletal traction. Then you need to clean the pin sites with what we call sterile saline with hydrogen peroxide or povidone, whichever one of them is prescribed, depending on agency protocol. You need to ensure that. So that is with the various forms of tractions that we have. Let me see if I can get images of these tractions so we can make use of them. I think I had some. Let me see if I still have them so that I can just show it to us so we can appreciate the various forms of tractions we have. Just so from here we go to we move on to cascade. Okay. So dropping these ones to our platform so we can appreciate it. I always want to use the pictures. So I have shared some of the images. Let me see if I can get them. Just a minute. Yes. So this is what I've been talking about. So this is skin traction. Okay. This is how, a typical skin traction is. So this is, the bandage that has been applied here with the foam. So that's why I was saying, you don't tie what we call the elastic bandage too tight on the client so that it could lead to compartment syndrome. So we have different types of the skin tractions. We have this is example of balance skeletal traction. So we know that with skeletal traction they apply pins. Okay, so this is where the pins are applied. So you can see that over here we have some form of pins that are applied here. Okay, so that is where you need to monitor, observe for infection and treat the area. Treat your infection and then clean the area to prevent any form of infection. So that is on skeletal traction. Let me see if I can get another one again. So for those, we have our back traction. So the back traction looks like skin traction. So this is how a back traction looks like. Then we have cervical traction. So we say cervical traction mostly used when you have upper extremity issue, okay, to help relieve spasms in the neck and then upper extremity injuries and all that. So you see that where the traction has been applied at the neck or the head. Okay, so this is the weight applied over here with your pulley systems here. Okay, this is our pulley systems, and it's a pulley system. We said that you need to ensure that there is no form of obstructions when it comes to the system. So that is on, images to help us understand whatever I was talking about. The next thing we talk about is cast care. Cast is very important. I believe that if you are here and you have learned about musculoskeletal, you are aware of cast care. And in cast care, what are we looking at? We are looking at, plaster of Paris, POP in our local terms, what we say. So plaster, fiber glass, or air cast are used to immobilize bones and joints into correct alignment after a fragment or injury. And so after injury, we know that after something like close reduction, the clients might need a cast in order to ensure proper alignment of the area. When it comes to cast, our duty as nurses learning for entrance is to know how to care for the client when the client is in cast, what to monitor for, what are the possible complications to watch out for. And so when it comes to cast intervention, you need to keep the we need to keep the cast and the extremity elevated. And so to help prevent what we call swelling and edema and all that, after the procedure, you need to make sure that the cast and the extremity is elevated. You need to allow a wet plaster cast 24 to 2 hours to dry. Mostly with the synthetic ones, it mostly dries within 20 minutes to dry up. You need to handle a wet plaster cast with the palm of the hands. Yes, so these are some of the things that the NCLEX is going to ask you. How do you handle a cast that is wet? Do you use the fingers, or where do you use to handle? So this is where these are the examinable things. And so you need to understand that if the cast is wet and you want to handle the cast, you need to use your palm to lift the cast. You are not, or the casted extremity, you are not supposed to use your fingers, because your fingers could cause indentation. So it can cause indentation. So you need to make sure, because of that, you have to put your palm, or you have to use your palm to lift the casted extremity that is wet. So for a wet plaster cast, you need to make sure that you are handling it with the palm of the hand and not the fingertips. And so it is dry, you need to turn the extremity every 1 to 2 hours unless contraindicated, to allow air circulation and promote drying of the cast. A hair dryer can equally be used on a cold setting. Look at what they are saying can be used. Hair dryer can be used, however, not the hot one. You know, when it comes to hair dryer, you can set it to produce what we call a warm air, and you can set it to produce a cold air. So you need to make sure that you are using a hair dryer with the cold setting. Okay, so a hair dryer can be used on a cold setting to dry a plaster cast. Heat cannot be used as a plaster cast because the heat can heat up and burn the skin. So when it comes to drying the cast, this is how some of the things you can do to assist with the drying of the cast. You can use hair dryer, but on a cold setting, not the heat setting. You need to monitor closely for circulatory impairments. You need to prepare for biovalving. That's when you suspect that there is compartment syndrome, or there is too much pressure within the cast, causing impairment with blood flow or circulation. And so biovalving, which involves or cutting the cast if circulatory impairment, so you might need to cut a part of the cast, okay, to relieve the pressure. Then you have to with Peter, we need to peter the cast or apply moleskin to the edges to protect the client's skin, maintain smooth. So it's about how you kind of mold the cast so that the edges will be too or be smooth to prevent any form of skin injury or skin impairment. So maintain smooth edges around the cast to prevent crumbling of what we call the cast material. So you need to, when the cast is applied, you need to make sure that the edges are smooth enough to prevent any form of issue with the skin. You need to monitor for infection, very important. If there is infection, temperature is going to go up mostly around the affected area, hot spots on the cast. So if you have a client who tells you that I am feeling some form of hot spots, okay, on the cast, there's foul smelling drainage and a change in pain, it all tells you that there is infection or there's something wrong. You need to assess further. If an open drainage area exists on the affected extremity, the healthcare provider will make a cutout portion of what we call the cast, known as a window for assessments and then wound care purposes. So for people with open drainage, or let's say, the wound is open and they still need a cast, the healthcare provider will create some form of opening on the cast so that the wound can be cared for and then you can assess the wound as well. You need to instruct the clients not to stick anything inside the cast. So you cannot, I believe we might have met questions like, the client comes to you, tells you that I am feeling some form of hotness or some form of discomfort in the cast, and makes a statement that I'm going to insert pen or anything, nothing should be inserted into the cast. Okay. So you teach the client that the client should not stick any object inside the cast. You need to teach the client to keep the cast clean and dry. You need to instruct them to also get involved in some form of exercise, asymmetric exercise, to prevent muscle wasting or atrophy. And then you need to monitor the casted extremity for circulatory impairments such as pain, swelling, discoloration, tingling sensation, numbness, coldness, or diminished pulses. You need to you need to notify healthcare provider if there is any of these assessments noted on a client with a cast in place. So when it comes to cast, one of the main things you are looking out for is what? Compartment syndrome. And so because of that, you monitor keenly for signs of compartment syndrome. When there is compartment syndrome, circulatory impairment is going to be there, or there is going to be circulatory impairment which will manifest with pain, swelling, discoloration of the affected joints. There's going to be tingling sensation, numbness, and then coldness or diminished pulses. And the client is going to make this kind of complaints to you when they are on cast, when they are in casting. So you need to monitor for these things. And then you report if any of these things exist. That is on cast care. We'll talk briefly on complications of fractures, and then we'll bring our class to an end for the first part of today's class. So, complications of fractures. The first thing you have to look at, or first complication we'll talk about, is fat embolism. And so, fat embolism is where you have, a fragment moving into pulmonary circulation, causing impaired gaseous exchange. So an emboli, which is, is caused by a movement of foreign fragments or foreign particle, which could be clots, which could be fats or air, into the pulmonary circulation, causing impaired gaseous exchange. Now, and so how do you know that someone is having fat embolism? In a question, it will definitely be described. After a fractured extremity, you assess your clients, you know that clients is probably having difficulty in breathing, saturation is around 80, 70 thereabout. Clients is in apprehension. All these things are things that could tell you there's restlessness and all that. It tells you that client is having what we call fat embolism, which is a complication of the fracture where a fragment has moved into what we call pulmonary circulation causing impaired gaseous exchange. And so on assessment, you expect to see restlessness, you expect to see apprehension, sudden onset of dyspnea and chest pain, cough, hemoptysis, and then hypoxia, crackles, and auscultation can all occur with a client with fat embolism. It is raining at my end, so if you are struggling to hear me, probably it is that, but I'll also try my possible best to increase my voice so that you can hear me. Sorry for that. So these are some of the things you will tell you in a question that this is fat embolism. Fat embolism, you need to interventions are to notify the healthcare provider when you notice that there is fat embolism. You need to administer oxygen because saturation is going down. There is hypoxia, and so you need to give oxygen. It's impaired gaseous exchange, so you need to provide oxygen support to the client. Then you need to administer IV fluids. Your anticoagulant therapy may also be prescribed if, let's say, there is a clot. Then you need to monitor vital signs, respiratory state is very important. X-ray will also help, as well as CT scan to confirm your diagnosis. You need to prepare the client for intubation and mechanical ventilation if necessary, as indicated by your arterial blood gas values. And so if you notice that the respiratory rate is very bad, saturation is very bad, you do your ABG and you realize that carbon dioxide level is very high, partial pressure of oxygen is very low, then it means that clients might need some form of mechanical ventilation or intubation. You need to document your intervention or your action taken and the client's response when it comes to the care for compartment, fat embolism. Yes, Madam Patricia.
Please, I don't understand why we use anticoagulant in fat embolism. Please, can you come clear on that? I thought probably it's blood clots that we use anticoagulant, but for fat embolism, I don't know why.
I'm struggling to hear you, but if I can hear you asking about where I made mention that we are going to use anticoagulant. Is that the case?
Yes, for fat embolism. I thought we use it for blood clots. I don't know how the anticoagulant will help with fat embolism. I just don't know how. I want to get that clear.
So I said that the cause of embolism, okay, could be as a result of clot, could be as a result of fat. So let's take this one out and talk about embolism in general. So the embolism will come in depending on the cause of the embolism. So let me take my fat embolism out, and then let's talk about what is causing the embolism. Is the embolism as a result of a clot? That is where there's going to be the use of the anticoagulant. Of course, if it is air embolism or it's a fat that has migrated into the pulmonary circulation, you're not going to use, anticoagulant. But if it is a clot that has migrated, definitely anticoagulant will be useful because of the clot. So look at what I said here with the causes of the embolism. So that is where the intervention will come in. And so I need to cancel this and make it a general embolism. Okay. Okay, thank you for bringing that up.
Thank you, Jay.
Yes, there was another hand up. Let me see if I could get the person. The one whose hand was up with room. Yeah, Madam Patience.
Hello, sir.
Yes, hello.
Thank you for the presentation. Please, so what's the
Yes, if you can help by putting your questions in the comment section, it will be helpful. Oh my God, I can't hear anything. Yes, Madam Patience. Can you put your questions in the comment section if you can type for me so that I will address it?
Okay, please, I'm doing that. Thank you.
Yes, Madam Patience, you can talk. Let me see if I can hear you.
Okay. So I'm saying that what's the initial action when you suspect fat embolism?
I am unable to hear you. Seriously. I'll be grateful if you can put the question on the comment chat so maybe I could read it and then understand what you wanted to mean. Okay, so yes, Mr. Paul has come in and saying that if there is a fat as a result of the embolism, they're going to be embolectomy. Yes, to remove the fat. Okay. Thank you, Mr. Paul. I saw your hand up. I don't know whether that was what you wanted to come in with it or you wanted to ask a question. But can you hear me? Let me know if you can hear me. Put it in the comment section if you can hear me. Can you hear me? So that I will continue.
Yes.
Yes, please. It's in the comment section.
Okay. All right. So yes, they say they can hear me. All right. So someone is asking, what's the initial action when you suspect that a patient suspect fat embolism? And then the position. Yeah, so when you suspect that a patient is having, let me come. Oh my God.
Salamingo. Hey, yes, Salamingo.
Yes, Madam Carol.
Okay, so the first thing is this patient will definitely be in distress. So you think about positioning in maybe fowler's position,
Yeah,
and then
let's raise the head
oxygenation,
side.
and connect the patient to oxygen.
Okay.
Oxygen. That's the first step.
All right. Okay, so positioning will be the ideal thing here. I mean, like they said, like Madam Caro is saying, you need to put the patient in a high balance position. Oxygen administration will come in as well later. But your position will be the first thing you have to do at the nurse here. And the ideal position is to ensure a high balance position. Or you leave the head side of the bed. Okay. It can also be used. So Mr. Paul, can kindness be given in blood clot embolism? All right, so it depends. It depends on, yes, the kinases are used to break the clots. You get me? And so it depends on the severity of it. If the healthcare, it all depends on the healthcare providers. That is why they are, blood thinners. So the kinases are used to break the clots totally. When it comes to the other ones, warfarin, heparin, they are to prevent the clot from enlarging and then the clot from extending and better clot from forming. But if the healthcare provider thinks that he should break the clots, of course, the kinases can be used to break the clots. Okay. Oh my God. Today, my class, the rain is disturbing me a lot. But let me see. So that is on the fat embolism here, or the embolism that can occur as a result of fractures. Let's talk about compartment syndrome. Okay. So on compartment syndrome, we are talking about a painful condition in which there is pressure increasing within or more compartment, leading to decreased blood flow, tissue ischemia, there is neurovascular impairment, and then it is a medical emergency. This can result in severe injury if it is not addressed quickly. So when we're talking about the application of cast, that is what you need to watch out for. Cast application can lead to someone developing compartment syndrome if the cast is too tight on the person. If the cast is too tight on the person, pressure is going to increase within the fractured joint or the extremity where the cast has been applied, where it is going to affect blood flow, or it's going to cause neurovascular impairment. And the neurovascular damage may be irreversible if it is not treated immediately within 4 to 6 hours after the onset of the compartment syndrome. It is mostly, common when the lower extremities are affected. So occurs common in lower legs. Now, when it comes to your assessment, I believe we have the 5P. I believe everybody here knows the 5 P's when it comes to compartment syndrome, right? So the 5 P's the 5 P's helps you with your assessment findings when you want to get your assessment findings with compartment syndrome. And so you have pain, you have pulselessness, you have poikilotemia, and all the other ones. So when it comes to your assessment, you have to assess for your pain. You need to assess for your pain, which is very important. So the pain talks about like increased pain in the limb. So the client will tell you that like the pain is so increasing. You get it? Then you have tissue that is distal to the involved area becoming pale, dust, and then edematous. So pale is also part of the P. So there's pain, there's pale extremity or dusky or edematous extremity. There's pain with passive movement. There's loss of sensation, that is paresthesia. So that is why you have the nerve involvement. And then we have pulselessness. That is a late sign. So the late sign of compartment syndrome is what we call pulselessness. Early sign will definitely be the pain the client will complain of. So severe pain that is unrelieved with any form of interventions like pain medication. Now, when it comes to your interventions for compartment syndrome, we are looking at it requires immediate intervention where you need to inform the healthcare provider. You're prepared to, assess your healthcare provider. You need to loosen tight dressing, bivalving, where you need to cut a part of the cast so that you relieve what you call the pressure. So bivalving restrictive cast as prescribed. If severe, you need to assess with fasciotomy. So fasciotomy to relieve pressure and then restore tissue perfusion is also indicated if the compartment syndrome is severe or is intense. The other complication with regards to fractures has to do with infection, especially if there is open or compound fracture. Open or compound fracture, you expect that infection is there. Those who make use of fixation, internal fixation, external fixation, those with skeletal tractions, they are all at risk of what we call infection and as a result of the fracture. And so osteomyelitis, where there is inflammation of what we call the bones. So infection and osteomyelitis, inflammatory response in bone tissues, which can be caused by introduction of organisms into the bones, leading to localized bone infection. And so we need to watch out for osteomyelitis as well as infection when you have what we call someone who is infected with or who is having a fracture or a fractured extremity. Your assessment, because it's infection, of course, you need temperature is key. So fever, most of the temperature will be more than 38.3. That is 101 Fahrenheit. There's going to be tachycardia. The affected extremity, there's going to be redness, erythema, pain in the area or area surrounding the infection. Leukocyte level is going to go up. There's going to be increased ESR levels with your labs. Then you might also need radiographic assessments such as plain radiographs, MRI, or bone scan to confirm that there's infection or there's any form of inflammation. When it comes to your intervention, I mean, healthcare provider need to know about it, so you need to notify them. You prepare, I mean, to initiate aggressive long-term antibiotic therapy. I mean, mostly given through central, I mean, access line. So, I mean, because you will be, I mean, the client might need their antibiotics probably for a long time, and then aggressive treatment. So long-term treatment, mostly done through a central venous access or line. Surgery may also be performed for people with resistant osteomyelitis with, I mean, sequestrectomy or bone grafting. Then you need to also, for unrelenting infection and the osteomyelitis, hyperbaric oxygen therapy is used to promote, I mean, healing. So it is a form of wound care, okay, especially in bone infection, where they are going to where they are going to use oxygen and other things in treating what we call the wounds, okay, to ensure proper healing. So here, I mean, pure oxygen will be given so it helps to ensure what we call bone healing, okay. And so that is with osteomyelitis. The last complication about bone or fracture is when you have tissue death, okay, or you have the bone death. So avascular necrosis. Avascular necrosis will happen when a fracture interrupts blood supply to a section of the bone, which will lead to bone death. When there is bone death, pain is going to be there. There's going to be decreased sensation. You need to, I mean, mostly confirm with, I mean, your MRI, your, I mean, radiography testing and bone scan. As interventions, you need to inform your healthcare provider about it. I mean, you need to watch out for any form of numbness that will occur. Where indicated, need to prepare surgically. And then necrotic tissues can serve as the focus for infection, and then can also lead to secondary arthritis if involving a joint. And so these are some of the complications that can arise as a result of what we call fracture, and then all the other things with regards to fracture.
Okay.
Yes, hello.
Can you please go back to the last slide?
This one.
Okay, thank you.
All right. Yes, any further questions here? Oh, sorry. Or any further question inputs? Any addition you think you want to add with regards to whatever I've said? You can bring it up before we go through the questions. Oh my God, I've struggled to deal with this rain. Okay. Everyone is quiet. All right. Then let's go through the questions. A client fell off a ladder, and the healthcare provider suspect a fracture of the right wrist. Which manifestation the nurse anticipates observing in the client? Select all that apply. We have crepitus, we have visible deformity, we have pain, we have cyanosis of the nail beds, we have absence of radial pulses or radial pulse. We are 88 members here. Assuming myself out means that I am talking to 87 members here. So I expect a lot of contribution. Or people respond, even if you don't want to talk. Attempt the question in the chat box. Is that easy?
Yes,
Guys,
it is.
yeah, you can go on.
Okay, yes, it is A, B, and C because D and E, the question didn't say that the phases are affected. So it's only fracture. And then they didn't also indicate that it is an open fracture where possible we can have the blood vessels affected. So that's why
Okay.
it's ABS.
ABCN. Okay. Someone said that I showed the answer. What was the answer? It was ABCN. That was a mistake. Okay. All right. So ABC, as Mr. Yusuf just said, I mean, in this instant, we expect to see that there is crepitus, visible deformity, or crepitation, visible deformities, pain. No indication in the question for you to think that it's going to be cyanosis. Just a fracture will not lead to cyanosis, and that will not also affect pulses unless there is complication where neurovascular, impairment is going to come. So yes, ABC is the most appropriate answer here. Let's look at this question. Which statement by the nurse describe a comminuted fracture for the client? Hey, this word, I have to go for classes on this word. Comminuted fracture. Which of this describes this form of fracture? We have the end of the broken bones are forced together. The bone is breaking through the skin. The bone is broken into many pieces. A fragment of the bone is separated from the rest of the bone. Madam Mary.
Thank you very much. I think number C, the bone is broken into many pieces. That's the answer. Thank you.
Okay. That Mary says that the bone is broken into many pieces. So she's going for C. Is there someone who thinks think the other way around? So cause C, comminuted fracture, you have the bone broken into many pieces. Okay, it may cause further injury or complication. Okay, so that is with comminuted.
Okay.
Yes, hello, madam.
Please, can I see the rationale for the previous question? My line went off, please. Okay, thank you, sir.
All right, let's look at this. Which clients should the nurse identify to be at the greatest risk of fractures whilst reviewing their health records? We have A, it's SATA. A, the client with leukemia. B, the client with bone neoplasms. C, the client who is malnourished. D, the client with osteoporosis. E, the client with hypercalcemia. Yes, so we have this question. They are asking about some. As I'm seeing a lot of answers. Yes, Madam Carol.
Say me, I'm trying. No.
Yes, try, Madam Carol.
So a patient with bone neoplasm here. Neoplasm is cancers, right? And then so I'll go
Yes,
for
yeah.
B. I'll go for B. And then C, the client who is malnourished. We know patients with malnourishment may lack calcium, they may lack other things. So I'll take malnourishment. And then the client with osteoporosis, that one, they're number one.
It's
So I'll go
automatic.
for D. Yeah. And then the clients with hypercalcemia. Say I was analyzing this one. I'm going for it. But I was analyzing it that and the parathyroid hormones, we said that when there is in hypercalcemia, the parathyroid hormones they'll pull the calcium from the bone into the blood. So you have excess into the blood, and then the bones will be left without
That is
calcium.
another way around that. I mean, of course, hypercalcemia can occur in the blood. But this time already, I'm not telling you the exact cause of this hypercalcemia. Well, let me leave it there. You want to add it, right?
Okay, well then BCD. So I was analyzing it. I was trying to analyze.
I was just adding up. I was just squeezing you to see, but it's fine. So you are going for B, C, D, E, right?
Okay.
Or you want to back down with the E?
Okay, so say you for now leave it there. If I'm wrong, I'm wrong. That's it.
All right. Thank you. There was another hand. Yes, Madam Tina.
Hello.
Yeah, hello, Madam Tina.
I agree with you that she said, but I'll add the leukemia to it. Because we know that leukemia too is a form of blood cancer.
Okay.
And if I remember correctly, the note didn't specify only bone cancer. So if the person has any form of cancer, it can also cause fractures too. Okay, so I'll take that one as well. Thank you.
So you are going for all of them?
Yes, please.
Oh, okay. All right, thank you. Anyone with a different view? Okay, let's make progress. We've gotten 2 contributions here. So that's why I was saying that leukemia is more of blood-related issues. Hypercalcemia, like I said, the question has not, in other way around, even in hypercalcemia, the excess calcium in the bone will be absorbed. Sorry, the excess calcium in the blood will be absorbed into the bone. So the part where the calcium in the bone breaks down is mostly when the person kindly mutes up for us. It's when the person is bedridden. When the individual is bedridden, not engaging in any form of activity, that's where you have the bone breaking down and then the calcium getting released into what we call the blood. Okay. But if it is hypercalcemia where the parathyroid gland is, excessively producing the hormone, then, the calcium will rather even move into the bones, and then it will ensure that, the client will have, strong bones. And like, we all know that leukemia is more to the blood. And if it's more to the blood, it's unlikely that it is going to really affect the bone. That is where they brought the bone fracture, the bone issue itself, the neoplasms of the bone itself, okay? The client with bone neoplasm. So that one was more specific. But we know leukemia is more of the blood-related issues. Yes, Mr. Paul.
Boss, it's about the hypercalcemia. I think if I remember it well, when I was listening to the spider woman, he made mention of hypercalcemia as a contributing factor because the calcium is more in the blood, it's not in the bone. So
Yeah.
I saw it that to prone the bone to fracture.
You said you saw it as, if you can come again, Mr. Paul.
I said one time I was listening to the spider woman
Yes.
and she made mention that in hypercalcemia, it will prone the patient into fractures because the calcium which is supposed to help to ensure bone function is not in the bone now, but it is finding more in the blood. So the bone, so the bone will not get the calcium for its function.
So you think that the hypercalcemia should still be part? Is that the point you are trying to make?
So that's how my mind was. That's how my mind was at first.
Yes, so that's why I was saying that yes, there are instances where you get someone with hypercalcemia, and then will tend to develop bone-related issues. But if you have, yes, and also the bone needs to be moved. Sorry, the calcium in the blood needs to be moved into the bone for the bone to use it. The body is producing excess, or the hormone that is making the calcium is being released in excess. So that's why the person has the blood. So under normal circumstances, the bone will rather have to move into the bone, and the person will develop strong bones. So hypercalcemia typically itself will not cause what we call bone issues unless the person is immobilized, where they are not able to utilize the bone, or where the bone is not able to move the excess calcium into, the excess calcium is not going into the bone for the bone to be used. And you know that exercise is good, so they will exercise and the bone will absorb the calcium in the blood. So that is where hypercalcemia can result in what we call bone-related issues like fracture. When the person is dormant, not working, and has excess calcium in the blood. But if you have excess calcium and you are working, like you are exercising, definitely the bone is going to drive the excess calcium, and it will even help with regulating your serum calcium. Well, I still have hands up. Madam Patience, you want to come in?
Hello, sir.
Yeah.
Please, I know that in hyperparathyroidism, we have hypercalcemia over there. And complication of hyperparathyroidism is osteoporosis as a result of hypercalcemia. And so, with this one, I think because you've chosen osteoporosis, hypercalcemia too can cause osteoporosis. So I think we should take it.
No, it's not like we should take. Yes, I understand. I've given you instances where hypercalcemia can lead to the bone-related complications. I don't know if the explanation I gave, whether it makes sense or not. But hypercalcemia itself will not lead to the person tends to having fractures unless the person is not making use of the bones, it's immobilized and all that. Madam Mary, your hand was up. You've dropped it.
Thank you very much.
Yes.
Thank you. I think the last time we had a discussion, you said those disused bones, like a client who is bedridden. Once the fellow body parts are not active, they tend to break down and they release calcium into the blood. That causes the hypercalcemia. But it's not necessarily directly that the hypercalcemia is causing
the hypercalcemia will cause it, exactly.
No. So
exactly.
I think that else. Thank you.
Yeah, all right. Thank you. It's just simple. I still have 2 hands. Is that easy? Is that easy for talking? We'll move on. I have to let my boss talk. Yes, my boss.
My point is that
Uh-huh.
if not because today we are dealing with fractures.
Yeah.
So if I see any question somewhere, and then they are mentioning hyper this in calciumia, whether it can cause this in fracture or not. Should I not go for that one? because you said that there are instances that hypercalcemia can cause fracture. So it means that virtually anytime you have high amounts of calcium in the blood, you take it that can cause fracture.
No. Let me retake the point again. Let me retake my point again. Hypercalcemia and fracture can. Let me take my point again. Hypercalcemia and fracture can occur, and that's how the two can occur. I'm taking it from where Madam Mary ended. Now, being inactive, being immobilized, means that the bone can break down. That is bone demineralization, where the calcium in the bone will be released. When it is really, I'm giving you instances where hypercalcemia can occur. Okay, where the parathyroid gland itself will produce excess, and then having the parathyroid gland having the hyperparathyroidism and calcium related disturbances coming in. The other way around is that when the person is immobilized and then the bone breakdown, the major component of the bone is calcium. So the calcium will be released into the blood, and in return, the person is going to have hypercalcemia. The fracture is not occurring because there is excess calcium in the blood. The hypercalcemia is occurring because the bone had broken down, and then all the nutrients had kind of vanished from the bone. That is why the person is more prone to fractures. Mr. Yusuf, am I making sense? I see. The fact is that hypercalcemia itself will not lead to hypercalcemia itself will not lead to fractures unless the person is mobilized. Well, we can read further. Let's just hang it there. Let's read further.
Yeah,
If you understand the
reading
point.
assignments.
You said I didn't answer you.
No, I mean it should be a reading assignment.
Yes. Thank you, Madam Karen. Which statement concerning bone fractures is correct? Select all that apply. Bone fractures do not result from low bone density. B. Bone fractures may result from repetitive force or twisting. C. A bone fracture can be direct result of excess pressure in the fibrous membrane or fascia. Diseases such as neoplasms do not cause bone fractures. E. The severity of a bone fracture depends on the force of the action. Depends on the force of action against the bone and the bone strength. Yes, this is Sata.
So my hand is up.
Your hand is up. Sorry, I didn't. Go ahead, Madam Carol.
So, sir, which statement concerning bone fractures is correct? A. Bone fractures do not result from low bone density. That is not true. If you have a low bone density, you can get fracture.
Okay.
B. Bone fractures may result from repetitive forces or twisting. That is true. So B is true.
Mm-hmm.
C. A bone fracture can be the direct result of excess pressure in the fibrous membranes of fascia. I don't think it's true.
Okay.
Because the bone is stronger than the fascias and the membranes. D, diseases such as neoplasm do not cause bone fractures. That is false. Neoplasms can cause bone fracture. And then E, the severity of a bone fracture depends on the force of the action against the bone and bone strength. That is correct. So B and E.
So you end up with B and E. Is that your final answer, Madam Carol?
Yes, sir.
Okay, thank you. So she's going for B and E. Yes, the one who also raised their hand can unmute, and let me see. But Mr. Paul, then Madam Adepa will come in. Oh, sorry,
Yeah, boss.
sorry.
I will also go for the B and A. B and E. Because the C one the C they wanted to be controversial guy, but because of the pressure in the fibers, if it happens that there's a pressure on the fibrous membrane or fascia, but in them is the problem.
In there,
So
okay.
the B and E, yeah.
Okay. All right. Madam May.
Okay, so me, I want to add the C to
You want to take the Rex, eh? I like the film.
I want to add the C because a bone fracture can be direct result of excess pressure. My concern is under the direct excess pressure. Yeah, that's where my point is. So depending on the let's say the constant of the pressure, it can lead to the fracture.
Okay.
And depending on which type of bone
It's
within that location.
affected. Okay.
Yes.
All right, that's fine. Thank you. So Madam May has gambled. She says she's adding the C to it. Mr. Easy, your hand was up, or you've dropped it now.
Yes, I dropped it. It's down now.
It's down. Okay, all right. So let's go on. So I mean the final answer is the B. Okay. So it just like Mr. Paul and then Madam Carol said, pressure within the fascia, I mean, will kind of rather restrict or reduce circulation to the muscles and then the nerves, but rather will not really cause fracture. Okay, so that is what we should understand. So BE, team BE, so Mr. Paul gave us a very good analysis where he said that, I mean, within that part of it clearly tells you that the issue is within the compartment and will not really result in what we call fracture. I've talked about this. Was that another question? It means I went back. Cannot even see. I have lights out at my end. Okay, this is a cast. Okay. A client sustained a radial fracture and a cast was just applied. The client states that there is unrelieved pain and numbness in the fingers on the affected side. Which intervention should be a priority? A, notifying the healthcare provider for cast removal. B, elevating the extremity. C, preparing for fasciotomy. D, performing frequent neurovascular checks. Sure, this should be the priority in a client with a cast as a result of a radial fracture, experiencing unrelieved pain, numbness in the fingers on the affected side. All right. We are going for A. All right. That Mary.
I'm going for A.
Hmm.
That's what is this term? It shows that the client because the 5 piece is part of complications of fracture cast application. That's what I'm going for that one. So you have to notify the care provider immediately. If not, the client will end up losing the limb.
Okay. All right. Yeah, Mr. Isif.
Oh, yes, I
You
was.
wanted to, you wanted to give us your reason.
Yes.
I saw you answered A in the comment section.
No, not me. Oh, yes. Is let's go back to the possible answer. Let's go back to the
Oh,
possible
it's not
answer.
you. But I saw A for okay, it wasn't you. Okay. I think it was someone else. That was Mr. Idrisu. Okay. I thought it was you.
Let me give my rationale for that.
You want to challenge the answer? Eh?
No, not that. You see, this I'm going to use assessment versus implementation. Looking at this situation, that's an emergency situation. So during emergency situation, you don't use assessment, rather use implementation. So that's why I won't go for D. That's performing frequent neurovascular checks, but rather I'll go for A, which is implementation and also related to the question or the modifying phrase. Yes.
And also, the thing is that they're asking for priority. McKay will say that when it comes to priority, the thing is like, if you look at all these four intervention, which of them that you the nurse, if you are to do all these things, that only one thing that take it as only one thing that you can do to save the client at this point. Do you think the neuro check should be the thing that should be done already in the question? There's even assessment in the question on relief pain and the numbness in the fingers. So clearly you need to go ahead, forget about assessment now. You are not the one to do fasciotomy. It will be done by a healthcare provider, so it's not you. And even though it is something that you need to prepare for it, but before you prepare for it, the healthcare provider will need to give you the direction on what intervention should be done. Okay. And then elevating at this point, if you have to elevate and leave informing the healthcare provider, will you elevate and leave it? Informing the healthcare provider? No, you would have to forego the elevation, inform the healthcare provider for care provider to know what is happening to your clients at the moment. So that is another way around you can also go about it. All right. So I think our time is up, eh? Let me see what we can do. I have a lot of questions here. Which statement from the client regarding CAS care requires additional teaching by the nurse? We have, I can use plastic shields around the cast while showering or bathing. B, if the edges becomes rough and rotating, I can remove the rough edges. C, I can apply ice to the cast and elevate my arms to prevent swelling. D, I should never place objects in the cast to relieve itching. So this question is asking us about cast care. Yeah, so Mr. Paul is even saying, yeah, it will cut blood supply to the extremity. So, yeah. So, this question, the question is, which statement from the client regarding cast care requires additional teaching? Mm, all right. So are we surprising what the answer is? Or someone is
Please,
ready?
can I look at the question? I beg you.
Hey, what am I doing? Hey, wait till a minute. Okay. You want to look at the question? The question was on for almost 5 minutes. This was the question. Now, the C is that I can apply ice to the cast and elevate my arms to preventing swelling. This even makes this part correct. Okay. Applying the ice packs will help relieve any form of pressure or discomfort. But if the edges becomes rough and irritating, I can remove the rough edges. This is a wrong statement. Client is not supposed to remove any edges. The client thinks that the edges are rough and other things. They need to report to the healthcare provider. Okay. So let's take note of that. Well, there's again just to close at 20 and 620. So maybe we do 1-2 more questions and drop it there. A client who was treated for a long bone fracture suddenly has a respiratory rate of 28 breaths per minute with an oxygen saturation of 86 on room air. The client is confused and restless. Which collaborative intervention is appropriate? A. Applying oxygen and continuing to assess respiratory status, intubating the client immediately immobilizing the pelvic area, administering corticosteroid as ordered. Okay. Anyone to talk? A, because of embolism. Dam Jamila. Dam Jamila has given us her rationale that because there is embolism, we need to give oxygen and continue to assess our clients, which is correct. Okay, so for this, we are all correct. And I think that is it. Everyone did well here. Mr. Paul, why were you going for B? Mr. Paul, how was the B? Intubate the
Well,
client.
the way the patient was confused, I thought of intubation.
Thought of intubating.
Okay.
Okay, so that would be after oxygen administration is unsuccessful. So you are even though, so if you look at the saturation is 86, not too bad. Okay, even though below 90, so you need to give your oxygen and now monitor to see if it's not improving. That's where probably you go in for intubation. All right. Which statement is correct regarding traction? A. Traction weights should rest either on the bed or on the floor. B. Skeletal traction may be used in conjunction with skin traction. Skin traction is contraindicated in older adults with frail skin. Skin traction is used when skeletal traction is contraindicated. Which of these, with regards to tractions, we think it's correct? All right. Assistive devices, like I said, the use of crutches, canes, and how clients supposed to use it. Okay. I know some of us might have read a lot about this, how to interpret it. In what situation do you think which client will make use of which of the gate system? Is it 2-point gate? Is it 3-point gates? I mean, is it 4-point gate? Is it sewing through? So we'll go through them and then try to see if we can understand them. But before that, we need to talk about crutch and how to use crutch for ambulation. When it comes to crutch, some of the important things that we need to know with regards to crutch has to do with how the clients would the crutch in terms of the measurements. It's very important. Then how the client's supposed to flex what we call the elbow. It is also to what degree is a client allowed to flex, and then what are the things clients will need to avoid when the client is using crutch. And I believe we all know crutches, that they are assistive devices that assist what we call people with lower extremity impairment or lower extremity issues like fractures, fractures, or let's say there is an injury, someone has had an accident, healthcare provider prescribes a crutch for the person to use. And so when it comes to crutch, you cannot just go and pick someone's crutch and start using. For instance, assuming I've had an injury and have been prescribed a crutch, and then you come to me, or you've also had a similar injury affecting your lower extremity, let's say even the same limb, and then you come to me that I want to use my crutch. It doesn't work like that, because my height and your heights are not the same, or might not be the same. And so because of that, you cannot make use of the crutch that I am using unless the healthcare provider, or unless they prescribe one for you, take your measurements, and so they know your length or your height, and so they can make one for you, the one that will suit you best. And so that is one thing that you need to understand. So when it comes to crutch, accurate measurement of the client for crutches is important, okay? Because when there is inaccurate measurement, it can lead to damage to the brachial plexus, okay? I mean, so it's because of that, that is why if someone is to use a crutch, the person will have to make sure that the height has been measured accurately, and then the correct measurement has been taken, and then the client has been given the correct crutch. This is to help prevent what we call, brachial plexus or damage to the brachial plexus. Let's say you go use a certain crutch that is too tight on you. Let's say you are short and you go and use a very tall person's crutch. Just imagine how it's going to look like on you. And so you could cause injury to some of the muscles. And so that is why you need to be avoided when, or you are not supposed to use someone's what we call crutch. We have, the next thing we have to also understand with crutch is that the distance between the axilla and the arm pieces of what we call the crutch should be 2 to 3 fingers width in the axillar space. In fact, this point is a very important point that everyone here will need to know this. That if you are measuring what we call the distance between the axilla and then the arm pieces where you hold on the crotch, it should be 2 to 3 finger width in what we call the axillar space. For this, however, you can keep it in your mind, because for this very statement, the ankles, they don't really change. All the questions I've met on crotch walking or crotch, this measurement always runs through it. That when you are to measure it, they must make sure that the distance between the axilla and then the arm pieces on the crotches should be 2 to 3 finger width in the axillar space. Then the elbow, how the client is supposed to also flex the elbow. The elbow should be flexed to 20 to 30 degrees when the client is walking. So you meet the question like that, the client will they want to understand if the client, the next ask the client to explain how he or she is going to use the crotch to ambulate. So you need to understand that when the client is ambulating with the crotch, how the client is supposed to flex what we call the elbow. It should be flexed at what? 20 to 30 degrees. It should not be more than 30 degrees. So it should be between this range, 20 to 30 degrees, in terms of the flexing of what we call the elbow when the client is working with the crotch. When ambulating with the client, you need to stand on the affected side. So let's say you have a client with a crutch and then you want to assist the client to ambulate, or let's say you want to assist the client to get out of bed. Where you need to stand is that you need to stand on the affected side of the client when the client is ambulating, or when ambulating with the client. Let's say you want to assist the client to ambulate, okay? Or let's say in the first few days of the how the client will have to use the crutch. Let's say the client hasn't used crutch before. You can't just throw the crutches to the client and pick your crutches and start walking. You need to assist the client to ambulate. So in that instant, when you are assisting the client to ambulate, you need to stand on the affected side of the client. Then you instruct the client never to also rest the axilla on what we call the axillary parts. You know, the axillary parts, I mean, that it's like foam. You've seen a crotch before. I mean, the axillar part is there. So the client is not supposed to rest on the axillar part just to prevent, pressure or to prevent injuries to the muscles there. So client will need to understand that they are not supposed to rest at the axilla on the axillar bars. Then you instruct the client to look up and then outward when ambulating, and to place the crutches. This is also a very important point. The distance to which the client would have to put the crutches if they are using the crutches to ambulate. It's also a very important point. We need to understand that the client will need to place the crutches 6 to 10 inches. That is about 25 to 25.5 centimeters diagonally in front of the foot. So the distance from the crutch to the client's foot should be about 6 to 10 inches when the client is ambulating with what we call the crutch. It should not be too far from the client, and it should not be also be too close to the client. So it should be about 6 to 10 inches diagonally in front of what we call the client. That is also a very important point that we need to know. You instruct the client to also stop ambulating or stop ambulation if they experience numbness or tingling in the arm or in the hands or arms when they are ambulating. So if the client tells you that whilst I was using my crutch to ambulate, I experience numbness, tingling sensation, the client will need to stop the ambulation and then rest. It could be that there is pressure that might have developed, or there is some form of neurovascular impairments. That is what is causing the numbness and tingling sensation. So client will need to rest. Probably you have to even report that to also the healthcare provider as well too. for that. So when it comes to crotch walking, these are some essential or important points we need to understand: how to measure the crotch, the angle the client's supposed to flex the elbow, and then the distance between the axilla and that of the arm pieces on the crotches, which is supposed to be 2 to 3 finger width, and then how the client is supposed to place what we call the crotches. I mean, in terms of so it says that client is supposed to place the crotches about 6 to 10 inches diagonally in front of the foot when they are ambulating with it. These are very essential points that we all need to know when it comes to crotch walking. Yes, so that is on crotch walking and what you need to know with regards to that. If you have any question or any input you want to make with regards to the use of crutches, basically measurement and all that, we are here to go through the various forms of gaits that we have if someone is using what we call crutches. And so we are going to talk about the gait system. And so the gait talks about how the client is supposed to move what we call the crutches. Okay, how the client is supposed to use the crutches, and in what form of injury would clients be prescribed what form of gaits. It is very important. So let's go through them. So gait system, we have the type of gait, the uses, and the procedure that is involved. I've kept it in a table form, so it will be very simple for us. So the first one would be 2-point gait. Now it comes to 2-point gaits. 2-point gaits, first of all, you need to know which type of injury or which type of client will be asked to use a 2-point gait. So we'll go through that, then we'll talk about how the 2-point gait works. Now in 2-point gaits are used by clients who can partially bear weight. That is a very important point. Clients who can partially bear weight. Okay, so we have that client can fully bear weight and the client can partially bear weight. If the client is asked to bear weight partially, then the most appropriate, okay, let me add up. Client is asked to bear weight partially, and then the client also has bilateral lower extremity impairment or limitation. So when I say bilateral, it means that both extremities are affected, because you can have partial weight bearing also in 3-point gaits. But 3-point gait is not, I will talk about 3-point gait. So let's stay on 2-point gait. So 2-point gait, I said that it is used when a client is asked to bear weight partially or partial weight bearing limitations with bilateral lower extremity prosthesis. These points are very important. The fact that the client is supposed to bear weight partially and the client has bilateral lower extremity impairment or prosthesis. So let's say client has had an accident, both extremities are affected, that is both legs are affected, and the client can partially bear weight. Client can partially bear weight, and they are asking you which type of gait system you are going to ask the client to use. You need to understand that if the client has bilateral lower extremity impairment or bilateral leg impairment or using prosthesis, and the healthcare provider makes a prescription or says that a client can partially bear weight, then the most appropriate form of gait system the client is supposed to use is 2-point gait. Now so that is the uses and who can use 2-point gait. Let's talk about how it works. So in 2-point gait, the crotch on the affected side and the unaffected foot are advanced at the same time. And so in 2-point gaits, what it means is that, let's say when you move the right, let's say this is my crotch, okay, and this is my legs, okay. So this is the crotch, this is leg. In 2-point gait, when you move, let's say the right, this is right? No, this is left from the screen. This is left, this is right. This is left, this is right. In 2-point gate, when you move, let's say the left crotch, you need to move it together. So the affected side and the unaffected foot are advanced at the same time. So you move the crotch, okay, on the unaffected side, and then the affected limb. Let's say the affected limb is the right one. I want to get this thing right, okay. The affected limb is the right one. And then you are to move the crotch. What you do is that you have to move the left leg and that of, or I'm saying that which one is my crotch? This is my crotch, this is my legs, okay. Sorry, let me start again. Let me do my drawings again. Sorry for that. So I'm saying that this is my crotch. This is my legs, okay. So, crotch here, leg here, legs here. Now, this is the right, sorry, this is the left crotch. This is the right crotch. This is the left leg. This is the right crotch. Hey, right leg. My right leg is affected. When I'm to move the crotch, I will first of all move the crotch on the affected side and the unaffected foot are advanced at the same time. So this is the crotch on the affected side, and this is the unaffected side. So when you are moving, it's like you move the opposite legs together. So you move the left crotch and then the right leg together at the same time. So you move the left leg, then you move the right crotch at the same time. Then the opposite also works out. So if you are moving the right crotch, you move the left leg. That is it. So you move left leg, right crotch, all at the same time. Then the opposite works. If you are moving the left leg, then you move the right crotch also at the same time. So that is if you have, let's say, bilateral lower extremity impairment. If it is only one, let's say only one leg that is affected, you have to move the crotch on the affected side and then the unaffected foot, and then you advance it at the same time. So that is how it works. Let me see if is there a question for me in the comment section? I don't have a video at the moment, so probably if you finish, you can look for the video and watch it, okay? I don't have a video of it at the moment, but I'm saying that in 2-point gates, you move the crotch on the opposite crotch and the opposite leg are moved together. Then when you are done, the remaining opposite leg and then the opposite crotch are also advanced together. So it's like at any point in time, you have, an opposite, a leg and a crotch on ground, okay? And then one crotch is being advanced, and then one leg is also being advanced together. I don't know if I'm making sense here. All right, so someone is saying that you can watch, someone has given a recommendation that you can watch on it from YouTube. Yes, so you move the affected crotch or the affected leg, which is, let's say, the left leg, and then the right crotch, you move it together. Then you come back, and then the other, and then the opposite one, you move it together again. Madam Tina, you want to ask a question? Ask a question, probably maybe the question will help me to give a better explanation. Yes,
Okay,
Madam
so
Tina.
I think I'm just making a suggestion.
All right.
the gates, I don't know whether you explained the gates before you explained you were explaining the types. Because I
Okay.
think if we understand what you mean by the gates, then that will help us to understand what you are saying. So for instance, the 2-point gate, the way I understand it, it's like you have one, like if it's a crutch, instead of using 2 crutch to be 1
Yes.
crutch, then
Yeah.
your 2 legs. So you moving, so now instead of, sorry, let me start again. So you have 1 crutch or a cane, then you have your
Yeah.
2 legs, right? Then
Okay.
what you are moving forward now becomes the gate. So if you are moving the crutch or the cane with the unaffected leg forward, then that means those two becomes the 2 gates. Is that how I should understand it?
Is that how you understand it?
Yes, that's how I understand it. But I'm asking, is that how it is?
I don't want to say that that is how it is, okay? But if that is
Okay.
what you understand it to be, then that is
Uh-huh.
fine, okay?
Because me understand it like if you are moving, if you are moving, what you
So,
move forward becomes the gate. So if you are moving 2 pieces forward, that is 1 crutch and then 1 leg forward, then those 2 becomes the 2 gates. If maybe
so,
you were using 2 crutches and you move the 2 crutches with 1 leg together, then that becomes the 3 gates. That's how I get it.
so I'm here to go to 3 gates, okay?
Okay.
I
Okay.
am good. I'm here to go to 3 gates, so that is why I'm taking it systematically. All right,
Okay.
thank you for that. Madam
Thank you.
Obapame. Yeah, Obapame, you can mute her or can unmute her.
Okay. So I just want to add a little to it. Like if I understand what you are explaining now, it's like usually your bad leg goes with the cane, or the 2 points is using 2 canes and your 2 legs.
Yes, yeah.
Good. So especially when you are climbing stairs,
Yeah.
it should be your bad leg and one of the cane going together, moving together. Yeah. And then you advance the good one to add on, yeah, and the opposite. So it's right left, like you said. And if the person is walking normally, if it's not stairs too, it's the same way it should go. The opposite, that's the right, the good leg goes with the opposite right
Crotch.
cane,
Yeah.
crotch, good, crotch.
Yeah.
So that makes the person have a strong gait.
Yeah.
But if the person move with the same, let me say, the right leg, the left cane, the right leg, the right cane,
The right skin.
yes,
Yeah.
the gait becomes unbalanced and the person
Balance
can
exactly.
easily trip and fall.
And fall. Yeah.
Yes, so I think is this that's the way you are explaining it. Is the I
Exactly.
think it's the right thing.
Exactly. Yes, exactly. Exactly. So I've gotten someone who is on the same page with me. Let me hear from Madam Ajua. Madam Ajua, you can unmute up and come.
Okay, hello, sir.
Yeah, hello, Madam Ajua.
Yeah, because I want to come in here.
Yeah, go ahead.
What I know about the 2-point gate is that at the moment, one of the crutches is on the ground together with a limb.
Yes, sure.
Yes. And so, first of all, you move the crutch on the affected side
Yeah.
together with the unaffected limb.
Yes.
Yes. So that after you move the crutch on the unaffected side with the affected limb.
Affected limb. Yeah, exactly.
Yes, so that you maintain balance.
Yeah.
Yes.
Yeah. So I think that was the same point I was making. So you move the limb. If let's say you have your right limb affected, when you are to move your K or your crotch, you have to move the crotch on the opposite, or the crotch that is on the unaffected extremity. Then when you are done, you move the other one also. Mr. Kabiru, you want to come in? You'll be the last person, then I'll go. Mr. Isi? Okay, I think he has dropped. Mr. Foster's iPhone.
Please, come again. Which one do you move first? Is it the affected leg or the unaffected one?
So the point is that I'm not talking about which one you move first and which one you move last. It is about how you move the crotch. Okay, that is what the concern is. It's not about which one you are moving first and which one you are moving last. What I want you to understand is that if you are moving the crotch, or how you move the crotch is that you move the crotch on the opposite side, and then the opposite leg the same time.
Okay.
You get it?
Yeah.
That is the point I am trying to establish.
All right.
So if your right leg is the one that is affected, if you are moving the right leg, it's supposed to go with the left crotch.
Yeah.
I hope you are getting that.
Yes. Yes.
That is how it's supposed to be.
Okay. Thank you.
Is there still hands up? I wanted to move on. Okay. Mr. Kabir, your hand is still up. I have not muted anyone. Try to mute all those who are unmuting. I mean, they did it themselves. So.
Hello.
Yeah, Mr. Kabir.
Yes, my own was different.
Okay, go ahead.
I want to add something about explain the point gate according to this Marquis. He's saying that the point gate is like referring to the number of points that like you have, like those part that is touching the ground, on the floor. Yes. So that means the 2-point gate means that one crotch and then one leg is down.
Yes, it's true.
And then 3-point gate means that 2 crotches are down and then one leg.
Yeah.
And then
4 points. At any point in time, all the 4 extremities are like on the ground.
Yes, they are down. So that's why they are with bearing.
Bearing, fully with bearing.
Yes. So that's why.
Yeah, all right. Thank you for that. Okay, so it's very simple. Okay, it's very simple, even though if you understand it the way we've done it, it will be very simple for. And like I said, the key things are in what situation you are going to use 2-point gate. It's very important that partial weight bearing and then bilateral, extremity prosthesis is also in place. Then how the ambulation or how they use is also, you need to know that. Then let's talk about 3-point gate. Okay, use for partial weight bearing or no weight bearing. And so if you get a question and the question says that the client, if you get a question and the question says that no weight bearing, and they ask you which of the gate systems you are going to pick, straightforward, you are going for 3-point gate. Okay, no weight bearing is 3-point gate. Okay, no weight bearing on the affected leg requires that the client have, strength and then balance. So in 3-point gate, it can be used for people with partial weight bearing or no weight bearing, and it is mostly also used by people with unilateral extremity impairment. And so let's say someone sustains injury and the injury affects only one extremity. Okay, the injury affects only one extremity. The most preferred point gait, or gait system the person has to use is a 3-point gait. The 3-point gait, like I said, mostly for unilateral lower extremity impairment, no weight bearing. Client has no weight bearing prescription or partial weight bearing, and then the client has unilateral extremity impairment. The system is that how the client's using. And so, like Mr. Yusuf said, at any point in time, the client has like 3 things on the ground, like 2 crutches and then an extremity. Okay, so at any point in time, the client has 3 kind of points on the ground. That is what I want you to understand. So both crutches and then the foot of the affected extremity are advanced together. So this one is very simple. The client advanced both crutches together with what we call the affected extremity. So let's say the affected extremity is on the right side, okay, or the right foot is affected, or the right leg is affected, and client is using 3-point gait. Client moves the 2 what we call crutches together with the affected extremity, and so that makes it like 3 things moving to the ground at the same time. So client moves the crutches, and then both crutches and the foot of the affected extremity are both advanced together, followed by the foot of the unaffected extremity. And so 3 things are going: 2 crutches, 1 leg, the affected leg, all going together. Then when that is done, the client will now move the unaffected leg and join. Then the movement continue like that. Continue like for 3-point gait, it is quite easy to understand. And I think most people has also been using it as well. There was a hand up. The person has dropped it. I saw a hand up in the person. So that is on 3-point gait. And so if you have a question on 3-point gait you want to ask, or you want to add up on 3-point gait, you can equally add up. It is very simple. Then on 4-point gait. So 4-point gait is used for people who can fully bear weight. So you have someone who has bilateral limb affected or bilateral lower extremity impairment, and they say that the client can fully bear weight, or the client can bear weight fully, and they are asking you which gait system the client is going to use. Client is going to use 4-point gait. So use if weight bearing is allowed and 1 foot can be placed in front of the other. Okay. And so let's say for someone who has sustained a bilateral limb extremity and the client is recovering, okay, after 2-point gait, they transition to what we call 4-point gait system. So mostly people who use 2-point gait ends up using what we call 4-point gait. At the time when the client can fully bear weight, the client will not use 2-point again, but rather will use a 4-point gait. So what goes into 4-point gait is very simple. It works like what we were talking about in 2-point gait. However, this time around, the foot and then the crutch will not move together. So you move it one at a point. So you move the crutch, let's say, on the left side first. Then when you are done, you move the foot on the right side. So left, right, left, right, left, right, like that. So let's say you are moving your first thing you are moving is the crutch, which is on your left side. So your left crutch first, then your right leg will follow up. Then when you are done, your right crutch, then your left leg will follow. Okay, so the right crutch is advanced, then the left foot will follow. Not together. Client move the crutch. When the client is done, the client will move the opposite leg. Okay, then the left crutch will be advanced, then the right foot will also follow up. So that is on 4-point gaits and how 4-point gaits is also used. Yes, Madam. Grace, right? I come. Sorry.
No, I'm
Yes.
not reading.
Yeah.
So it means the 4-point gate is just like walking.
Yes.
Okay.
Yes, it's just
thank
like
you.
walking. It's just like walking. So that is why it is like people who can fully bear weight, they have sustained the injury and then they are recovering. Okay. And they can now like control the crutches and their leg very well. That is where they use what we call the 4-point gates. Any further inputs here? Now, let's talk about swing to gate. So we have swing through and we have swing to gate. So swing to and swing through. So swing through means that like you move your leg through the crotch, and then swing to like you move it to what we call the crotch. So let's look at the two. So we have swing to gate, which is used when there is adequate muscle power and the balance in the arms. In what goes on in swing to is that both crutches are advanced together, then both legs are lifted and placed down on the spot behind the crutch. And so client moves the crutch, both crutches together to a point. Then both legs will also move. The client will like lift the both legs too, and then place it behind what we call the crutch. So client is not going, above, or is not moving after the crutch. You understand? The client is not going more than the crutch, but rather just put it behind what we call the crutch. And then afterwards, the client will continue again, lift the two crutches forward, and then both extremities or leg will also move together, or the client will move both legs together. That is what we call the swing to. The feet and the crutches form a tripod when the client does that. So swing to is that the client is going to move both crutches, which are advanced together, then both legs are lifted and placed down on the spots behind what we call the crutches. That is with swing to. Then we have swing through, which is used when there is also adequate muscle power and balance in the arms. What goes on in swing to is that both crutches are advanced together, then both legs are lifted through and beyond the crutches. So in swing through, after advancing the limbs or the legs, they go beyond what we call the crutch, and it's like the crutch will be left behind. You get it? And then beyond the crutches and placed down again at the point in front of the crutch. So exactly. So we swing to the legs will be behind the crutch, but rather and then in swing through, the legs will be in front of what we call the crutches after both legs has been advanced. That is on swing through. How it is also used. This is how that one is also used as well. So these are the gate systems that we need to know and how they work, or how clients will need to use them when ambulating. If you have a question, you have an input you want to make on swing to and then swing through, you can also add up as well. Or you can raise up your hand and then you come in. Then let's look at how to use a cane or a crutch when the client is advancing, or the client is going up a stair and then coming down a stair. This is also something that we need to know. And so if client is using either a cane, or the client is using a crutch and the client is to move up on a stair, like client is supposed to climb a stairs, how is the client supposed to ambulate with it? Or client is supposed to come down a stairs. Client is on top, client needs to come down, the client has an injury, client is using a cane to ambulate. How should the client ambulate with what we call the cane or the crutch? Is very important. And so when you are going up the stairs, the client will move the unaffected leg up first. So we say that going up the stairs, you move the good leg first. So the client moves the good leg up first. Then the client will then move the affected leg and the crutch or the cane together. You get it? So when the client is going up the stairs, the client will need to move the unaffected one first. When the client is going up, unaffected one first. Then when the client is done, the client will now move the affected leg and then the crutch or the cane together onto what we call the stairs. And the client will continue like that, and the client is done with his or her ambulation. Then when the client is coming down, this time round, the client will move the crutch and the affected leg down first. So when you are descending, it is now the affected leg and then the crutch or the cane. That is what comes down first. Then the unaffected leg will follow up. That is on how the client will need to go up and down when the client is using a crutch or a cane, when the client is ambulating up and down the stairs. Canes and then walkers are also made for, lightweight bearing, are made of, lightweight materials with a rubber tip and what we call the button. So one of the things you need to watch out is that when you are using either a cane and walkers, there are some instructions or some certain interventions that you need to put in place for a client who is using what we call a cane or a crutch, because it is mostly used or made using a lightweight material. So material that is not too heavy, something that client can easily lift. That is what they use in making what we call canes and walkers. And then it also has what we call a rubber tip at the bottom. So you need to even watch or monitor the rubber tip for any form of wear and tear, so that to prevent falls. So when you are using a cane, you need to stand at the affected side of the client when ambulating. So just like we talked about in what we call crutch, if you are to when you are to ambulate and you are to assist the client to ambulate, you need to stand on the affected side of the client and assist the client to ambulate. Use of a gate or a transfer bed may also be necessary, especially if you need to transfer the client from what we call the bed. You need to the handle should be at the level of the client's greater trochanter. So for those that are using what we call cane for ambulating, when they are to ambulate, they must make sure that all the height of the cane, the handle, should be at the level of what we call the greater trochanter. The greater trochanter is at your thigh end. Okay, so we can just Google and look at where our greater trochanter is. So with canes, the handle should be at the level of the greater trochanter. When a client is using a cane for ambulating, the elbow should also be flexed at least an angle of 15 to 30 degrees. In terms of the angle, you need to instruct the client to also hold the cane 4 to 6 inches, that is about 10 to 15 centimeters to the side of what we call the foot. You need to instruct the client to also hold the cane in the arm on the unaffected side, so that the cane and then the weaker legs can work together with each step. So if someone is using what you call so if the client is using what we call the cane, they must make sure that you instruct the clients on how to handle the cane, that the cane should be in the hands that is on the unaffected side. Okay, So if let's say the right foot is affected or the right leg is affected, the cane is supposed to be in the left hand. Okay. The left hand must handle what we call the cane and then must move together with the affected leg, which is the right leg. Then you instruct the client to move the cane at the same time as what we call the affected leg. You instruct the client to also inspect the rubber tips regularly for, worn places or worn out. Because the client will be using it all the time, it can wear off. And when it wear off, the client can slip off and then fall, and injury can set in. So that is on how clients are supposed to use a cane when the client is ambulating. Yes, Madam Sarah. Madam Sarah, you can unmute up and then come in.
Yeah, so can we use the same principle as in the two gates? Can we use replace the cane with the crutch? Is it the same principle?
Crutch is different from it. Crutch is different from a
No,
cane.
I mean with the movement, you said with the two gates, the crutch, we move the crutch first at the unaffected side. So with the cane too should also be at the unaffected side and move. That is what I'm asking that.
Okay, yes. I thought you wanted to replace a crutch with a cane.
No. I'm talking about the movement. Which one to move
yes,
first?
exactly. Yes.
Because there are too
Anytime
many. There are too many. Like the scenarios are many. So
yeah, the scenarios are many. Yeah, exactly. So if you are using a cane, okay, the cane, cane is always, one. Okay, it's going to be one. Okay. So if the client is using a cane, the client has to hold the cane in the unaffected side. And then when the client is advancing, advance the cane and then the affected extremity together. Then the unaffected one will follow, depending on where the client is going. If it's a normal walking, for that one, it doesn't matter. But if the client is going up a stairs and coming down, you use the same, procedure as I talked about with going up and down the stairs. Yeah, Mr. Yusuf, your hand was up. Okay, let me unmute you, Mr. Yusuf. I don't know what the issue is. Yes, Madam Abdurrahman, I know you are. Yes, Mr. Yusuf. Okay, Mr. Yusuf is ready. Now let me listen to Mr. Yusuf.
Yes, I have a concern with this one. The point 2, the client move the affected leg and the crutches up. The first one is okay, but then the next one is not okay for me.
What's wrong with it? If you can let me know.
The client move the unaffected leg up first. That's the good leg.
Yeah.
Okay, so fine. That's correct. Then this one, the second one, the client moves the affected leg and the crutches up. That means that the bad leg, the bad leg, and then this and the crutches up. Do you see that? The client moves the affected leg and the crutches up.
Yeah.
So the two are not the same.
Which one?
They are contradicting. Your point 1 and 2.
No, Mr. Yusuf, hold on. Which one are you talking about when the client is going up the stairs?
Yes. Hello. What I know is that
I get your point. Wait, yes. I'm saying that this is the procedure involved when the client is going up the stairs or when the client is climbing the stairs. These are the procedures involved. What has to happen is that when the client is going up, listen to me. The first thing the client does is that the client will move the unaffected leg first, put it on the stair. Then when the client finishes, client will move the affected leg and the crutch together onto the stairs. Then if there's another stairs, client will do again, moving the unaffected one first. Then the affected one and the crotch will also follow up together. That is what that point is saying. But how do you understand the 2 points? You think they are all saying the same? The two are telling you the procedures involved. That when you are going, you go with the unaffected leg first. Then when you are done, you advance the affected one and the crotch together. And then it continue like that.
Okay, the process involved, right?
Yes, this is the process involved. The 2 points. The 2 points are talking about the process involved when one is going up the stairs.
Okay,
so the first point is telling us that is what the client has to do first when the client is going up the stairs. Then when the client is done, the client will now move the crotch and then the affected leg together as a second procedure.
Yes, I get you.
Okay.
Thank you. That's what the life class is better.
It's like using. Yes. It's Abdurrahman. Are you also having challenge with unmuting? So that okay, let me see if I can unmute you. You can put your questions also in the comment box if I'm kind of yes. Have you been able to unmute? Okay, yeah, you can go ahead.
Hello, please, with the elbow flex, the angle, please, the first slide, it was 20 to 30 or...
That is crotch.
Okay, that was the
cane. This is cane.
The first one, I thought 20 to 30, and this slide, I'm seeing 15 to 30. That's why I'm a little bit...
Yes, I get your point. Thanks for clarifying. It's very good. Okay, madam.
So please, which one is the...
Which one is the...
I'm saying that the first one was 20 to 30, and this one is...
Yes, and I said that was for crotch. Crotch is different from cane. So if the client is using a crotch and the client is to ambulate, client is supposed to, flex the elbow to 20 to 30. If the client is using a cane, it is 15 to 30.
Okay, thank you very much.
You're welcome. Mr. Foster, your hand was up as well. Why is it that others are able to unmute and others are able to mute? Sorry, are unable to mute, others are able to unmute. Oh. So once I'm asking so you can unmute, I don't know what the problem is. Have you tried unmuting Mr. Foster so we can make progress? And then Mary, try to see if you can unmute yourself. If not, I'm trying to unmute you guys. It's not working at my end. Like I said, you can, yes. Yeah,
okay,
go ahead.
Thank you very much. I was asking a question. At what duration should you use the cane before changing the rubber part of it?
The duration there. So the thing
Because
is
I saw one question on that. Is it on the kill bank? But I can't remember.
Okay, they gave a time duration.
Yes, please. I don't know. Is it 3 months or 6 months?
Okay, I stand to be correct. I'm not sure of the actual duration a client will need to change, but the point is that client will need to inspect the tip of the rubber that has been used and to see whether it has worn off, and so that if it has worn off, the client will just need to replace. But for the actual duration, I am not too sure of it, so I wouldn't want to give any comment on that. But if anyone has also seen any question on that and with that time duration, the person, because the reason why I don't want to give the time, it could be that I mean, the person might have not used the cane for maybe very long time, and then the cane is still there, okay, and they maybe use it for just some short period of time, and then the rubber tape hasn't worn out. Client can use it again if there is a need. So for now, let's stick to the fact that client will need to inspect the rubber tapes regularly for, worn places, so that if the client will need to change it, that is when the rubber soles might have worn out. If you also equally have any question you want to ask, you can bring it up. Mr. Foster, I could not hear from you. Okay, is there a comment for me? Yes, so Mr. is even say is making a contributing that someone who uses it more frequently, yes, definitely the rubber will wear off than someone who does not really use it more frequently. So that's why I don't the time there, I'm not too sure of that. Okay. Mr. Foster, I could not hear you. If you are still with me and want to come on board, you can put a question on the comment section and then we deal with it. If that is okay for you, because I'm unable to hear you at the moment. So that brings us to the end of the gate systems and then the assistive devices and all that. Okay. We'll talk about fractured hip, basically on the intervention for someone with a fractured hip, what the person is supposed to do. And after someone has gone in for open reduction internal fixation, that is what the NCLEX mostly asks you. That is ORIF. What are some of the things you need to watch out for? What are things you need to do for your client? So we've talked about fractures and all that. So fractured hips means that the hips are fractured for whatever reason or whatever cause it. We've talked about some of the various causes of fractures. And so with hip fracture, mostly clients will need an open reduction, and then screws, bolts, and then metallic parts will all be joined together, okay, to ensure stability. So when someone goes in for open reduction internal fixation and then client comes back, the post-op interventions are what we need to know, and that the client we need to monitor for signs of delirium and then institute safety measures. So delirium, which is temporal memory loss or disturbance, mostly comes about in this instance if the person goes in for the procedure, comes back and the client probably loses a huge volume or large volume of blood, and the client is probably running into hypovolemic shock. Or shock. Delirium can set in, and you need to institute your safety measures. You need to make sure that you maintain the leg and the hip in proper alignment. You need to prevent internal or external rotation, okay, and then avoid extreme hip flexion. So the extreme hip flexion mostly comes about when the client is maybe want to go and use the washroom. And so you realize that one point they mostly say you have to let the client use high toilet seats. Okay. These are to prevent extreme flexion of what we call the affected hip or the hip. You need to follow the healthcare provider's instructions regarding how to turn the client and reposition. Usually, turning to the unaffected side is allowed. Protective devices may also be prescribed. So when you want to position someone with a hip fracture who has gone in for ORIF and the client is back, you need to make sure that if you are to position, you cannot position the client on the unaffected side. So mostly the client is mostly have been positioned on the unaffected side. And then you can elevate the head of the bed to about 30 to 45 degrees for meals only if you need to. Elevate the head side of the bed. The degree that you can go is 30 to 45 degrees when a client is wants to eat. This is to help prevent aspiration. You cannot let the client lie down flat and then feed the client. You need to assist the client to also ambulate as prescribed by your healthcare provider. You need to avoid any form of weight bearing on the affected leg as prescribed. You need to instruct the client in the use of how the client will use walkers to avoid weight bearing. And then weight bearing is also often restricted after ORIF and may not be restricted after total hip arthroplasty. So it means that, I mean, the entire hip, with total hip, I mean, arthroplasty, they mostly do not restrict them in terms of weight bearing because the entire hip has been replaced. And so for that one, they do not undergo what we call weight bearing restrictions. But if there's ORIF, definitely weight bearing restrictions will be there. You need to always refer to whatever the healthcare provided instructions are. Keep the operated leg extended, supported, and elevated, preventing hip flexion when getting the client out of bed. So if you are to assist the client to move out of bed, you need to make sure that you keep the operated legs extended and supported, and then you elevate it when the client is to get out of bed. This is to prevent what we call the hip from getting flexed. You need to avoid high flexion more than 90 degrees. Then, and also avoid low chest when out of bed. So that is why if the client is going to use toilets, they will need to make sure they are using high toilet seats in terms of WC. Then you need to make sure that you monitor the wound for any form of infection and then hemorrhage. You give your antibiotics to, I mean, as prescribed, okay, and then to prevent infections as well. You do your neurovascular assessments, color of the affected extremity, pulses, capillary flow, movement, and sensation. So you monitor if there is any form of impaired neurovascular or there is any form of neurovascular impairment. You need to maintain the compression of the drain if present to facilitate wound drainage. So some of them will go in and come back with drainage tube to help remove excess fluid or blood. Okay, so in that instance, you need to make sure that you are monitoring the amount, the color, and then so you can report if there is any form of abnormalities and to ensure that the wound facilitate drainage. You need to monitor the drainage, the amounts, and then all that I talked about. You expect that as the client transition through or recovers, the amount should decrease. If the amount keeps increasing, that is the drainage, then probably the client is bleeding, you might need to report. So the drainage will need to decrease as the client transitions through the recovery process. Then you have to, as prescribed, need to carry out your post-operative blood salvage to collect, filter, and reinfuse your client. So in order to also prevent what we call hypovolemic shock, this procedure is a major procedure. So clients will lose a lot of blood. And so most of the time, the client's own blood are used to reinfuse. So if that is also prescribed, we need to do that. You need to use anti-embolic stockings or sequential compressive stockings as also prescribed. This is to help prevent issues of what we call DVT. Okay, and so encourage the client to flex and extend the feet to reduce what we call risks of DVT. And then so anti-embolic stockings are applied here to help reduce risks of DVT. You instruct the client to avoid crossing the legs and then activities that requires bending over. So that is where clients are supposed to flex the hip. Okay, so clients are not supposed to flex the hip. So any intervention that will cause the client or anything that will require the client to bend down, the client will need to avoid that. And then physical therapies will be also instituted post-operatively with progressive ambulation as also prescribed by the healthcare provider. So mostly these people are mostly referred to what we call the physical therapists to also come in and assist the client with ambulation and all that. That is with someone who had a hip fracture and has gone in for open reduction internal fixation and comes back. What are the things you need to do for your clients? Those are some of the things we need to observe and do for such clients after the procedure. We talk about the next one, which is total knee replacement. So with total knee replacement, it involves the implantation of a device to substitute for the femoral condyles and then tibial joint surfaces. So if you need to replace a knee, that is what we are talking about. Here too, it is about our interventions. That is what it's concerned to us. But it's going to ask you to define total knee replacement to them. The pre-op interventions are generally the things we know basically, but when the concerns are that when the client comes back, how do we care for these clients? That is where the concerns are. So with post-operative interventions after total knee replacement, you also need to monitor the surgical side for drainage and infection. I mean, the client will need continuous passive motion. So continuous passive motion is like a device that is applied to assist the client, okay, to provide continuous kind of ambulation, okay. It helps to provide what we call continuous ambulation or kind of movement of the joints. And so the device helps with control range of motion. It helps patients to recover and regain their mobility. So they come back with it, and probably there's a prescription that the client must use continuous passive motion, which a device would have to be attached to the affected joint or the affected extremity to ensure that there is that continuous movement of what we call the joint. You need to administer, because of pain, you might need to administer your analgesics to help control the pain before the client uses CPM. And then you need to prepare the client for out of bed activities as also prescribed. Have the clients avoid leg dangling. So for people who goes in for total knee replacement, when they comes back, they are told not to. We are told not to, or they are told not to dangle the leg after total knee replacement. Then weight bearing with an assistive devices is also prescribed. We've talked about the various assistive devices. So depending on whichever one is prescribed for the client can make use of it. The same thing, the client's own blood can be used to re-infuse the client because of the amount of blood that can be lost during the procedure. Tranexamic acid, we know it's also useful to help prevent what we call stop bleeding. Okay, so tranexamic acid is often given during procedure, as it has been shown to reduce blood loss and the result in fewer post-operative transfusions. Antibiotics are also very important to help the client if the client requires, or the client will definitely need what we call antibiotics to help them prevent infections and all that. That is with total knee replacements, and then what you do for the client after total knee replacement. Then we come to the last part, which will talk about amputation of the extremities. And so with amputation, we know that we've all seen people who have had injuries or sustained injuries that requires them to be amputated or amputated. So with amputation, the removal of a limb or a part of the limb, complications can include hemorrhage, infection, phantom limb sensation. Now, when we talk about phantom limb sensation, we are talking about having a feeling or a pain at the joints where the joint is no more available. So painful perception that an individual experiencing or painful perception that an individual experiences, okay, relating to a limb or an organ that is not physically present, okay. So with people with what we call amputation, one of their major things that they do, experience is phantom limb sensation and pain. And then they also develop some form of neuroma and then flexion contractures. So look at what a client will need to do to prevent these forms of flexion contractures. Basically, before we go into the two types of amputation that we have, post-operatively, if client comes back from what we call or client's limb has been amputated, the client comes back, you need to make sure that you monitor for the complication. We talked about bleeding, infection, then phantom pain or limb sensation. Then you mark bleeding and drainage on the dressing if it occurs. So what you are doing is that you are monitoring for any form of bleeding. So when the client comes back and you notice that there is any spot of bleeding on what we call the dressing, you need to mark there so that you mark, like you kind of circle the spots so that you can now monitor to see whether the bleeding is ongoing. Because when the bleeding is ongoing, you realize that the spots will extend beyond the mark that you did. And that means that client is probably bleeding and require you to inform the healthcare provider about that. You need to elevate for phantom pain, phantom limb sensation and pain. You need to explain it to the clients that they will have this form of what we call sensation and pain. So explain sensation and pain to the client and need to medicate the clients. And so pain medication, and then one of the most effective intervention that is used is what we call the TENS or TENS unit. TENS is transcutaneous electrical nerve stimulation, which is where low voltage electrical current is used to relieve the pain. And so people with phantom limb sensation and pain, they use what we call TENS. It's TENS. So transcutaneous electrical nerve stimulation, where electrical impulses or voltage are generated or are used to relieve what we call. So it has a machine. The machine is attached to the limb, and then electrical current are passed through it and to help reduce or manage what we call the pain. That is what we call the TENS. It is used in controlling what we call phantom limb sensation and pain or phantom pain after amputation. You need to, so phantom pain can be a very debilitating or can be a debilitating symptom following amputation. Mirror therapy with assistance of a trained therapist can also be helpful in controlling what we call this symptom. So these are some of the things together with what we call the TENS I was talking about. So they also use the mirror therapy with assistance with a trained therapist who have come in and then assist the client with this form of treatment. To prevent the hip contractures, you need to make sure that the client do not elevate the residual limb on a pillow. Okay, so the residual limb should not be elevated on what we call a pillow if you want to prevent what we call hip flexion. So you need to let the client understand this, that they are not supposed to elevate the residual limb, okay, on a pillow to prevent what we call the hip from flexing. Then first 24 hours, how the client is supposed to elevate what we call the client has to elevate the limbs. First 24 hours, elevate the foot of the bed to reduce edema. Then keep the bed flat to prevent what we call hip flexion contractures, if that is prescribed. So first 24 hours, the client will need to elevate the foot of the bed to help reduce edema. Then after 24 to 48 hours post-operatively, the client is also placed in what we call prone position, okay, position the client prone to stretch the muscles and prevent hip contractures if that is also prescribed. So first 24 hours, the foot end of the bed is elevated to reduce edema. Then after 24 to 48 hours, or after 24 to 48 hours, client is placed in what we call a prone position to help stretch the muscles and prevent what we call hip flexion contractures. And so these are some of the things that we need to do. You need to maintain surgical appliances, surgical application of dressing, elastic compressive wraps, and then or elastic stamp, that is residual limb shrinkers as prescribed to reduce swelling, minimize pain, and then hold the residual limb in preparation for prosthesis. And so because the client will need prosthesis, they will need to make sure that they use what we call shrinkers. The shrinkers will shrink the residual limb, so that if they want to apply a prosthesis, it can be easily for it to be applied. So the client might be asked to use dressing, elastic compressive wraps, so that it will help the joint to shrink, or the residual limb to shrink. We also have the elastic stamp as well. As prescribed, wash the residual limb with mild soap and water and dry it thoroughly. You need to massage the skin towards what we call the suture line, if that is also prescribed, to minimize scalp tissues and prevent its adherence to underlying bone. So the skin towards the suture line, okay, should be massaged if it is prescribed. You need to prepare for prosthesis use, and then instruct the client in progressive resistive techniques by gently pushing the residual limb against the pillow. And so to help the residual limb to also fit into the prosthesis, the client is asked to press the residual limb against what we call the pillow, and then progressing to firmer surfaces, so that they can, when they are using the prosthesis, it becomes very easy for it to fix. You need to encourage the client to verbalize their concern. In fact, this comes about, or this brings about, what we call issues of disturbed body image. Okay, so allow the client to verbalize their concern, assist the client to identify coping mechanisms to deal with the loss. Support groups such as the amputee coalition can also be helpful with the clients in terms of how they cope with the lost extremities. So that is general interventions, or these are general post-operative interventions for amputation. Now, after amputation, which ones are, so we have interventions for below knee amputation, and then interventions for above knee amputation, together with whatever I have said. Okay, and so because there are two different types of amputation, there are some specific interventions that goes with each of the types. So you need to understand the types and then which intervention goes for them. So when it comes to below knee amputation, to prevent edema, you do not allow the residual limb to hang, what we call, so you need to prevent edema. We've talked about how to prevent edema by elevating the foot end of the bed within the first 24 hours. Then do not also allow the residual limb to hang over the edges of what we call the bed. So you know that with below knee, you still have part of or a residual limb will be there. Okay, if I'm done, I'll try to show you a picture of how it works. Okay, of how it works, or how below knee amputation looks like. I think we all might have seen it before. You have like a residual limb hanging, and so to prevent that, you have to make sure, or you do not allow the residual limb to hang over the edges of the bed. You discourage the long period of sitting to lessen complications of knee flexion because there is a residual limb. The client is not supposed to kind of sit for too long to prevent the hips from hanging or flexing. Then place the client in a prone position throughout the day as prescribed by what you call the healthcare provider. So these are specific instructions or specific interventions for a below knee amputation. For above knee amputation, so with above knee, you know that there is no any form of residual limb because the amputation is above the knee. So there's not going to be what you call a residual limb. You need to prevent internal or external rotation of the limb. Place a sandbag that is rolled towel. So the trochanter roll is here. So the trochanter roll is like you roll a towel. It's like a towel you have to roll. You put it at the trochanter and then alongside of the thigh. So like I was telling you, our greater trochanter. You see the greater trochanter is like our thigh, the side of our thigh, and so you have to provide that kind of support to what we call the lower extremity, and so or the amputated end. So you place the either sandbag, a roll towel, or if you have the trochanter roll there, okay. And so if you don't have a trochanter roll, you can replace it with what you call the rolled towel along the outside of what we call the thigh to prevent external rotation. So in preventing external rotation, what you do is that you apply what we call the trochanter roll to prevent external rotation. Place the client in a prone position throughout the day as also prescribed by the healthcare provider. And so client is also placed in a supine position, so a prone position for above knee amputation if there is a prescription for the client to be placed in a prone position. At this point, this will be the last thing I'll talk about here for the first part of my class before we go into the questions and try to assess ourselves on whatever has been discussed. If you have an input, I said TENS is transcutaneous electrical. Let me get it well for you, okay? I want to get you. So I said it's transcutaneous electrical nerve stimulation, okay? Transcutaneous electrical nerve stimulation. That is the TENS. Okay. Yes, so is there any question, any input, any clarification? All right. Please, how is the electric? Please, how is the elastic compressive wrap done? Okay, let's go and watch a picture of how elastic compressive, but it's like, I mean, a bandage, very elastic one, which is wrapped on what we call the residual limb. But like I said, let me go in here, and so I will show you. So I'm still waiting if you have a question. So elastic compressive wrap. Everything. So Madam Rama, this is how it is, okay? So you just use it to wrap the residual limb, okay? This is how it looks like. So to help the area to shrink. So let me see if I can add something for amputation. Let me see if I can get the one that is used on amputation. Amputated leg. Okay, so this is it. Okay, so Madam Rama, this is what we are talking about. So any further question here, input here? It means we are okay. Yeah. Okay, let's do this question. Your patient is prescribed to use crutches for ambulation. Yes, ambulation. The patient can bear partial weight and needs to be taught how to use the 2-point gate whilst using crutches. Which prescription below best describe this type of gait with crutches? A. The patient moves both crutches forward and then moves both legs forward to the same point as the crutch. B. The patient moves the right crutch, that is injured side, then moves the left foot, non-injured side, and then moves the left crutch, the non-injured side, and then moves the right foot, that is the injured side. C. The patient moves both right crutch, injured side, and the left foot, non-injured side, forward together, and then moves the left crutch, that's a non-injured side, and the right foot, injured side, forward together. D. The patient moves both crutches and injured legs forward together, and then moves the non-injured leg forward. Yes, who is ready to talk for us? I want someone to talk. Yes, we've gone through this, we've dealt with it very well. So I believe that if you are here with us, yes, who is ready to come in? Yes, I've seen your answers in the chat in the chat box, but I still want someone to tell us what is happening here. Okay. Hello, Mr. Yusuf and Co. Where are you? My usual commentators. Mr. Yusuf, Mr. Paul, about Pame, your hand is up. All right. About Pame, can meet up. You cannot mute, sorry.
Okay, thank you, sir. I'm going for C because we established that with 2-point gates, patients should move the affected limb with opposite side of the crutch to get a better gait, a balance, in other ways.
Okay.
So that is why I'm going for C. The others, A, B, and D, doesn't describe 2-point gate well for me. That's what I'm going for.
All right. Madam Mary, you can come in. Okay, I think Madam Mary has dropped her hand. Madam Ajua. Sorry. Madam Ajua, should I unmute you? I'm still not. Okay, try to see if you can. Yes, so Madam Ajua, you can go ahead. Yeah, hello, Madam.
Yeah, the answer is C, but
The answer is C.
I want to start from the A, yes.
Okay,
So the A is the patient moves both crutches forward and then move both legs forward to the same point as the crutches. So this is a swing to gait, swing to.
Okay.
B, the patient move, this one is 4 gates.
Okay.
And the C is 2 gates.
All right.
And the D is 3 gates.
3 gates. Okay.
Yes.
All right. Thank you.
Mm.
Is Madam Mary, do you still want to come in? If you can show your hand so I will call you. I will just unmute you. Try to unmute you. Okay, let me see if I can unmute you. I don't know why others are able to. Yes, so.
Okay, hello, thank you.
All
I
right.
think that the 2-point gate, you have to always hold the crotch at the unaffected leg. Then you move the crotch at the unaffected leg with that of the affected leg together. That's the 2-point gate. So C is the appropriate answer.
All right. So I think we all agree with the option C as the best answer here, and that is it. Based on what we learned before we got here, we learned that in 2-point gates, you move the both leg and then like the leg, affected leg and the opposite crotch together, and then when you are done, the opposite the affected leg and then the opposite crotch, you move it together. So I believe after here, nobody will get a question on the gate system and the person will struggle to come or to answer it. The second question is this question says that whilst your patient is ambulating with crutches, he moves both crutches forward along with injured leg and then moves the non-injured forward. When you document, you note that the patient used what type of gate whilst ambulating with crutches. Is it 2-point gate? Is it 3-point gate? Is it 4-point gate? Is it twin two? So this question is asking us a certain form of gate system has been described in the question, and they are asking us what type of gate system has been described, or as a nurse, if you notice a client using this form of gate system, what are you going to document as being the type of gate system the client is using? Very easy. All right, I know that this one, it's a walkover. I mean, it's a 3-point gate. You move both crutches and the injured leg together, and then an injured leg will follow up. So we said that it is used when the patient has a unilateral lower limb limitation, or only one leg is affected. And we said that it's mostly for non-weight bearing or partial weight bearing with one leg affected. That is where the client uses a 3-point gate. So this is very simple for us to understand. Yes, this question is also on gates. You are demonstrating how to ambulate whilst using crutches to a group of patients who will need to use crutches after surgery. You ask one of the group participants to demonstrate the 4-point gate using the crutches. Which demonstration by the participant demonstrate they understood the demonstration you provided earlier. You have A, the patient moves both crutches forward and then moves both legs past the placement of the crutches. B, the patient moves both crutches and injured leg forward together and then moves the non-injured leg forward. C, the patient moves both right crutch and the left foot forward together and then moves the left crutch and the right foot forward together. D, the participant move the right crutch, then move the left foot, then moves the left crutch, then moves the right foot. So which of these demonstrates where is Madam Ajua? should I unmute? Let me see. Damajua, your hand was up. If you can show your hand again, or you've dropped it. Okay. Try to see if I've unmuted you now.
Okay, hello.
Yeah, hello.
Okay, so A, the participant move both crutches forward and then moves both legs past the placement. This is a swing through gait.
Okay.
And number two, B, the participant moves both crutches and injured leg forward together. That is 3-point gait. C, participant move both the right crutches and the left foot forward together. Then that one is a 2-point gait. So the answer is D. The participant moves the right crutch, then moves the left foot, then moves the left crutch. Then yeah. So the D is the answer.
All right. So is there anyone who thinks the answer? I saw someone going for A, or was it B? The one who chose, the person is using numbers. I wanted the person to tell us why he or she is going for. We have said that all of us should try to use our name so that we can. But I saw someone, person was using numbers. Okay. But is there anyone who thinks the answer is different from what our sister just said? So we all understand that what has been described is 4-point gait, and in 4-point gait we said you move. It's just like 2-point gait, but this time around the leg and the crotch will not move together. Crotch first, opposite leg. Crotch first, opposite leg will move. So you move it one at a time. Okay. That is with this. All right. And next is planning a plan of care to prevent client from developing flexion contractures following a below the knee amputation 24 hours ago. Which of the following actions should the nurse include in the plan of care? A, limit any type of exercise to the residual limb for the first 48 hours after surgery. B, position the client prone several times each day. C, wrap the stump in a figure 8 pattern. B, encourage sitting in a chair during the day. So which of these interventions will help prevent the client from developing flexion contractures following below knee amputation? Yes, if you want to answer, you can raise up your hand. I will mute you. For us. I want someone to talk for us. Today, why are my guys? Mr. Yusuf, Mr. Paul, and the rest. Madam Caro, are you with us today? Or today, Madam Caro is not in class? Today, I have not heard from my Madam Caro. Yes, Madam Caro, you are around. All right, let me see. Try to see if you can unmute. Okay, you can do that. So,
I'm not answering the question. I was very late to class, so I didn't hear anything.
Oi.
I'm just following. I was asleep, so.
Hey, today the time. All right.
I just joined.
All right. I wanted to just hear from you if you were there.
Thank you.
All right. Okay, so who want to answer the question for us? Okay, those going for B. Tell us why you're going for B. Those going for B, tell us why B. Hey, no one is ready to talk. We are keeping our answers. Okay, Mr. Yusuf. I'm sure I have to unmute you. Okay, let me try that. Okay, you can go ahead.
Okay, it is B because we said the B prone position will help increase muscle strength.
Okay.
And D is out because D gets like sitting like gets at the edge of the bed and then letting it down, like that leg to swing down. So that's why yeah. So that's why I'm moving D. And then the A said that limit any type of exercise. Limiting any type of exercise is not good.
It's not good. So the word any
type of exercise at all. So that one is out. So this B is okay. And then wrap this one, wrap the stamp in a figure 8 pattern. I think that one is okay. But then it is B.
All right. Thank you. So, like he said, the answer is B. He has said everything. So the rationale is what he said. And we know that we learned that after amputation, in order to prevent flexion contractures, clients would have to assume prone position several times during the day. And so that is why the answer is B. All right. Another question here. A nurse is caring for a client following a below the knee amputation. Which of the following actions should the nurse take? It is select or that apply. A. Encourage dependent position of the residual limb. B. Inspect for presence and amount of drainage. C. Implement shrinkage intervention of the residual limb. D. Wrap the residual limb in a circular manner using gauze. E. Assess for feeling of body image changes. Yes, if you want to answer, you can unmute or raise up your hand. I will mute. Yes, Madam Tina, your hand is up. Take us through.
I would choose B, C, and E. For the A, encourage dependent position of the limb. I don't understand what it means, so I won't pick it. Then inspect for presence and amount of drainage. You have to check for that, especially if they are like bleeding. And then if there are drainage containers attached to, you have to make sure that they are draining well, there's no kink or there's no blockage. And then it says implement shrinkage intervention of the residual limb. I think that is where you have to bandage it well in the 8-figure shape, so that with the stretching bandage, so that if we are supposed to fix
prosthesis.
Yes, prosthesis, it will be able to fit well. Then it says wrap the residual limb in a circular manner. We know that we are not supposed to do it in a circular manner. So that one too is out. Then assess for feelings of body image changes. By all means, the person will have some kind of reaction to a body part missing. So I would go for that one too. So I'll choose the B, C, and then the E. Thank you.
Okay. All right. BCE. There was another hand. Is the hand still there or is dropped? The hand is dropped. All right. Who else would want to tell us why he or she is going for? Okay. So Steve.
So my own is also B, but then I'm going to give reasons why I'll not include A, because that one can cause hip contracture. And then D, this one is a rule to say, or protocol to say that don't use circular, but rather the 8 figure, or they use like a spiral.
Okay.
Spiral or 8 figure. So that's why I'm like, those are the reasons I'm using to eliminate A and then D, leaving B, C, and then E.
Okay. All right. Is that Paul? Let me unmute you.
Okay, boss.
Is Paul? You can go ahead.
I'll go.
Oh, the line is breaking. Can you repeat yourself again? Can you start again?
My sister said I don't really understand the dependent position, so
okay.
Myself. And D, wrap CE, BCE, then position. So maybe when you are done, then you explain that. When you even wrap with gauze, shrink enough for the prosthesis, because mostly what they use is the elastic bandage, so that the remaining limb can shrink very well for the prosthesis. So the gauze cannot even make the residual limb being well shrink.
Okay. All right. Thank you. So let's move on. Okay. So encourage dependent position of the dependent limb. Okay, so how do we add that? Besides, if is trying to explain what the dependent position is to us in this case, that the dependent position is where you have the limb hanging freely on what we call the leg, okay, or the residual limb. But so yes, it means that the position where the legs, dangles or hang down due to gravity. So in this instance, let me confirm this. But we understand that when it comes to the B, C, and E, we need to do those things. But when it comes to the residual limb, I'm coming. Yes, Madam Sarah, you can come in. Yes, let me unmute you. I want to confirm something before.
So I think if you want to change it the other way, if you encourage independent position, independent means that you are not touching the limbs, you are not doing anything about the limbs. And when the limbs heal, there will be a contractor.
Yes.
It means that the particular limb will be at a particular distance. It wouldn't be able to bend down, extend, or flex. But when we encourage a dependent position, it means that we'll be manipulating, like we are changing the position, we are wrapping the stump, we are doing something about the limbs. there is extension and flexion of the limb, so that when the limbs heals, there wouldn't be any contractures. Otherwise, it will be stuck at one end.
So I'm on you again, Madam Sarah. So do you think that it should be encouraged or not? Madam Sarah, come back again so that you. I wanted you to conclude for me. Madam Sarah, yes. Let me, Mr. Yusuf, I've unmuted you. I want you to come in.
So okay, the dependent position is like positioning the body part in a way that gravity can act on it.
Yes.
So yes. So with this one, when you put it in that position, blood and fluid will pull down.
Will pull down, leading to the swelling.
Yes, and edema. Yeah.
Yes. Yeah. So yes. So I think the A should be taken out. Okay. So because like they said, when you look at, the dependent position, it will lead to the swelling occurring. And if swelling occurs, that should not be done. Okay. So if you look at the meaning of dependent, it says that keeping the residual limb in a lowered position, such as hanging down, which can lead to increased swelling due to gravity. So the final answer here, I think it was where I picked it from, supposed to be the BCE. Okay, so let's take note of that. Then gait. So I want to talk about gait again. Okay, this is it about crotch measuring. This is still on gates. I want something else which is not on gates, still on gates. Crunch. Patient needs to go, okay, going up and down. Okay. A patient needs to go up the stairs whilst using crutches. What finding by the nurse demonstrates the patient understand how to ambulate upstairs with crutches? A, the patient moves the crutches forward up the step. Then the injured and non-injured leg. B, the patient moves the non-injured leg forward onto the step and then moves the injured leg and the crutch up. The patient moves the injured leg forward onto the steps, then moves the crutches and then moves the non-injured legs. D, the patient moves the crutches and an injured leg forward to the step together and then the non-injured leg. So based on what has been said, which of this means that the client is demonstrating an understanding on how to go up and down the stairs using. Okay, Madam Mary hand is up. Let me call Madam Mary. Madam Mary dropped it. I wanted to unmute you. Okay. Who else? Okay, Madam Sarah wants to come. Okay, Madam Sarah can go ahead.
So with the moving up, the patient needs to go up while using crutches. So that one, they said the patient moves the non-injured leg forward. So the good leg goes up first. Then the crutch follows. The rest of them, they are all the crutches moving forward. All of them are the crutches moving forward. So I'll go in for the B.
The
The
B.
first one is the A is we are moving a crotch, so I'll eliminate that one. Then the B, we are moving a non-injured leg. That is the good leg first. So that one can stand aside. Then the C, the patient moves the injured leg. So no, the bad leg doesn't move forward. Then the third one, the last one, the patient moves the crotch and then the non-injured leg. So all of them, the good leg or the non-injured leg moves first. So I'll go in for the B.
Okay. All right. Thank you. So she's going for B. She's Madam Mary, I've unmuted you.
Okay. Thank you very much. You know, the rule is that good up, bad down.
Okay.
So if you apply good up, bad down, definitely the good leg have to go up, followed by the injured leg, then the crutches. Do you understand? So I'm taking B. Hello.
Yeah, Madam Mary, I can hear you. Yeah, I got you.
I said good leg up, followed by the bad leg.
I got you. Thank you. Yeah. Yeah, Mr. Yusuf, last one.
Okay, so my own is that it is believed that the heaven is in the sky, and then we all want to go to heaven. So it is good to go up. So that's what they said: up with the good and down with the bad. So that's my method.
Okay. So your final answer is which one?
It's B.
It's B. Okay. All right. So let's see our final answer. I think we all agree that it is the B. Okay. Based on what we learned and what our colleagues have also said. Hey, where is the question? Where is the option D for this question? Why did I drop it? Whilst going down the stairs with a crutch, the patient will move the crutches down onto the step followed by A, then an injured leg onto the step. B, moving the injured leg down onto the step. C, moving both legs onto the step. I think the answer is still in there, even though my my D is not showing. I don't know where I left the D. I think when I was putting the questions together. So, Madam Mary, I've unmuted you.
Okay. Thank you very much. I think it's the B. Good or bad down. So we have to go by that rule.
Yes, thank you. I think Madam Ajua, I've unmuted you. Try to see if we can come in. I've seen your hands up as well. Yes, Madam Ajua. Okay. I'm not getting her.
Hello, sir.
Yeah, hello.
Is B, moving the injured leg down onto the stairs. This is the right answer. But sir, please, I want you to go back to the last two questions before this one.
Last two questions. Okay.
Before this one.
This one or that one? Is it this one? Or this? I think this is what we did. This one. The one that we spent a lot of time on it. Is that one? Madam Ajua, are you still with me?
Yes, please.
So is it this question?
Yes, please. I didn't get the answer. I went off.
So the answer was B, C, E. My selection added the A, but we got to understand that the A clients is not supposed to position the residual limb in a dependent position, because it can lead to swelling, because when the residual limb is hanging in a dependent position, it will hang freely, and so blood can pool to the residual limb and leads to swelling or edema. So it should not be done. So BCE was the final answer.
Okay. Thank you.
All right. So I think our time is up for today, and so we can end our class here. I've seen a lot of people have already dropped out, or they've already left the class. And so we can drop it there. Then, God willing, Friday we'll meet again. We'll talk about the conditions, and then we'll close from there.